we'll start.
हेलो डॉक्टर किरण।
हाय, हेलो डॉक्टर शशि, कैसी हो आप?
बढ़िया, आप कैसे हैं?
हेलो डॉक्टर किरण,
नमस्कार मैम।
So
बढ़िया,
this
नमस्कार।
has Namaskar everybody. I welcome you all to the 201st edition of Happy Learning Masterclass, and we are now live on YouTube. So I would, Patel sir, with your permission, I would start the session, please.
Yes, you can. Am I audible?
नमस्कार पटेल
Yes,
सर।
sir.
Namaskar,
Hello, sir.
namaskar.
नमस्कार सर।
Namaskar. Am I audible?
यस सर।
यस सर, यस।
Yes.
नमस्ते।
I am traveling from Gurgaon to Meerut, and I am in cab.
ओके।
Okay.
नमस्कार पटेल सर।
Namaskar, namaskar.
Nice to see you, sir. Your dedication.
Good
Thank
evening,
you.
Manju
Thank
ma'am.
you.
Good evening.
Thank you.
हेलो, गुड
Manju
इवनिंग
madam,
एवरीबॉडी।
welcome.
गुड इवनिंग।
मंजू मैडम नमस्ते।
So I welcome everyone to this 201st edition of Happy Learning Masterclass. We are live now. And before we start the program proper, I would request everyone to join in for a short prayer.
वक्रतुंड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देवा सर्वकार्येषु सर्वदा। असतो मा सद्गमय तमसो मा ज्योतिर्गमय मृत्योर्मामृतं गमय। ॐ शान्ति शान्ति शान्ति।
Now, I would like to introduce the coordinator for today evening, Dr. Rekha Rajendrakumar ma'am. She is the president of Bangalore Society 24-25. We all know how efficiently she's done the last conference, the FemCon, and she has many awards and felicitations, articles. She is first rank in MD, 7th rank Bangalore University, All India topper at ICOG Reproductive Medicine examination, and is a very, very accomplished gynecologist and a dear friend. Requesting you, Dr. Rekha, to please give a brief introduction of me before we go ahead.
Yeah, thank you so much, Dr. Asha. Thank you, M.C.Patel sir, for the opportunity. Dr. Asha is the MD, TNB, MNAMS, MBA, FICOG, and she's a Kathak Vidwat. She has passed also. She is the director of SMSA Hospital in Raipur, medical director of CPRS. She is also the elected member of CG Medical Council, Chairman Mission Pink Health IMA Raipur, as well as Executive Committee member of Indian Society of Colposcopy. She was the president of Raipur Society, vice president of IMA Chhattisgarh, and Foxy. Her center is a Foxy recognized center for colposcopy and ultrasound training. So she has a very rich academic experience. Her fields of interest are saving the uterus, fetal medicine, gynecobstetric ultrasound, critical care, as well as preventive oncology in colposcopy. Dr. Asha is standing for the election of chairperson of Food and Drug Equipment Committee this year. The election dates are from 16th of August to 25th of August. I request all the dignitaries who are here, the faculty as well as the audience, the dignitaries to vote for Dr. Asha. And thank you, Dr. Asha, for giving me this opportunity.
Thank you so much, Dr. Rekha. I'm sorry I had to involve you, but to read my CV, but I
Yes.
actually need that help. Thank you
Absolutely
so much.
fine. Absolutely fine.
Now, I would stop sharing the screen and I would request MC Patel sir to give his formal welcome address to this August gathering. As we all know, MC Patel sir is standing for president this year. The voting is from 1st August to 10th August. And he is such a committed person. This is 201. So he is very consistent, very approachable. Requesting you, sir, please give your welcome address.
Traveling, so maybe some difficulty
Maybe,
in the
yeah.
connection.
He's traveling. He was in the car only.
Yeah.
Okay, so then I will start the program proper, and when sir can hear, then we will ask him to give his welcome address. So we start the program proper. I welcome each and every person who has joined this webinar, all our specialists and dignitaries, and also the delegates on behalf of MC Patel sir. Now we go ahead to the inauguration proper. I would like to introduce Professor Achla Batra ma'am from Department of Obstetrics and Gynae, VMMC and Safdarjung Hospital, New Delhi. She is the immediate past president of AOGD, President Narchi, Delhi Chapter 18 to 20, Chairperson Urogynec Committee, AOGD, Chairperson Rural Health Committee, Honorary Secretary, ex-editor Narchi, Coordinator for Foxy Critical Care Conference 2016, Yuva Foxy North Zone 2018. She is a dedicated PG and UG teacher for the last 35 years. She's conducted research projects for LSTM, ICMR, and Indo-US projects. She is author of Workbook of Obstetrics, CBS Publishers 2015, and she has contributed several chapters in books, authored several original research papers, which have been published in international and national journals. She's a reviewer in national journals and has contributed to several Ministry of Health and Family Welfare guidelines. We are really honored to have you here, ma'am. I would request you to please share
Thank
your
you,
words of wisdom to this webinar.
Thank you, Dr. Asha. And I can see Dr. Patel also now. Namaskar, Dr. Patel.
Thank you, madam.
As always, the webinars are always about simple things which people must know: the chronic pelvic pain, sepsis in pregnancy, and MTP amendment. As he is a simple person, but truly dedicated and always working for the people. So this webinar has been convened by Dr. Asha and Dr. Rekha. Very nice selection of topics. I think we will really learn some tips and tricks, not that chronic pelvic pain is something very, very common and so many women are affected by it, but how to go about it and diagnose it and treat it, we are going to learn. So I wish this webinar a great success and all the best to Asha ji, Rekha ji, and Dr. Patel. Thank you.
Thank you so much, Achla ma'am. Thank you. So
Thank you, madam.
today we have four contestants actually on this webinar. Dr. Mala Srivastav is there.
Thank you,
Patel
Dr.
sir,
Achla.
Anita Rajorhia ma'am is also there, and I'm there. Rekha will be doing next year.
Okay,
So
okay.
We wish
thank
all
you,
a
ma'am.
great
Thank you for
success.
those wishes.
Mhm.
And requesting MC Patel sir, please give your welcome address, sir.
Thank you, Dr. Asha. Sorry for some connectivity issue because I am traveling. But anyway, it gave me immense pleasure to welcome you all to this 201st episode of Happy Learning Masterclass web series. I welcome Dr. Achla Batra, Dr.Manju Puri, and Dr.Asmita Rathore. They have kindly consented to be guest of honor to bless the webinar. Of course, they are always with me in any of my academic activity. So thank you all of you, Dr. Achla, Dr. Manju Puri madam, and Dr. Asmita Rathore madam. I also welcome Dr. Shakuntala Kumar. She is going to discuss very interesting topic today, that is chronic pelvic pain. And to chair that very interesting session, I also welcome Dr.Mala Srivastav and Dr.Renu Chawla madam. I also welcome Dr. Susheela Gupta, Maheshwari madam. She is going to discuss maternal sepsis, and to chair that important session, I welcome learned chairperson Dr. Renu Dr. Renu Mishra madam, and Dr. Punita Mahajan madam. And as far as panel is concerned, we are going to discuss MTP Act and its amendment, what gynecologists should know. And it is a reverse panel. Panelists will be asking a question, and being a moderator, I will be answering. And to welcome all those learned panelists, Dr. Deepa Gupta madam, Dr. Shalini Chawla madam, Dr. Susheela Gupta madam, Dr. Kiran Agarwal madam, Dr. Anita Rajorhia madam, and Dr. Kiran Chhabra madam. I welcome you all and all the delegates who have joined this webinar. I also welcome Dr. Asha Jain. She is convener in this series since long. And I also welcome Dr. Rekha Rajendrakumar. She is also coordinator since long in this series. I also welcome Dr. Shakuntala Kumar. She is also one of the coordinator for today's webinar. And I put on record my special thanks and deep sense of gratitude to Dr. Shakuntala Kumar. She has helped me a lot for this webinar, not only designing, but to execution of this program. Thank you, Shakuntala Kumar madam, for sparing your time to help us in our academic activity.
Thank you,
So,
sir.
in era of COVID, when I started this series, it was my aim to just meet our Foxian friends on virtual ground and to discuss focused topic and to say hello to all. And with grace of God, with blessings of senior and support and help from all the friends, we are today with 201st episode of that very masterclass, Happy Learning Masterclass. So we have traveled all the society of Foxy 3 times, and this is our 4th round. Sorry. So without wasting much of your time, I hand over to Dr. Asha for further proceeding. Thank you very much.
Thank you, sir.
Thank you, sir. Now I would request Dr. Rekha Rajendrakumar ma'am. Would you please introduce Dr. Manju Puri ma'am?
Yeah, thank you. Dr. Manju Puri madam is a well-known figure.
Already late हो गया है.
या किसी थोड़ा बंद कर सकते हैं क्या ऑडियो? Yeah, Madam Manju Puri is a well-known figure. She's a director, professor, Department of Obstetrics, Gynecology, Lady Harding Medical College, New Delhi. Awards are FRCOG honoris causa last year, FOCOG, the Foxy Movicol Award in 2022 for the best scientific research work, Dr. L.H. Lobo Oration in 2022, Foxy Achievers Award. I would, yeah, thank you. She has edited lot of books.
Excuse me,
anemia
may I
and
know who's
pregnancy.
speaking? If you
Yeah.
would please mute yourself.
We are happy. Edited books are Anemia and Pregnancy, Clinical Methods in Obstetrics and Gynecology, Management of high-risk pregnancy, a practical approach, etc. Madam has a rich obstetrics gynecology experience. Recently, I heard her talk on labor difficulties. Thank you, madam, for being a guest of honor. Thanks for accepting our invitation. We would like to hear from you, Dr. Manju Puri, madam.
Thank you, Dr. Rekha, for a kind introduction. And thank you, Dr. Patel and Dr. Asha and Dr. Rekha for having me here. And it is indeed a great pleasure to be part of this beautiful series of happy learning. As the name says, it delivers all the information in small packets. So it is not it doesn't cause burden. And two small interesting talks are going to be there by Dr. Shakuntala and by Dr. Susheela on very important topics. Chronic pelvic pain is something, we still do not make that diagnosis so often, whereas we have a whole lot of patients who are suffering from chronic pelvic pain. So I'm glad that this topic is here because it needs a multi-modality management, and the patients they suffer a lot. And as far as the maternal sepsis is concerned, we all know that that's one of the number one killers. And mainly the mothers die because of sepsis, because of delay in diagnosis, because of subtle presentation sometimes, and delay in initiation of management. So I'm sure Dr. Susheela is going to, do justice to this topic and sensitize everyone on how to diagnose it fast and how to initiate treatment early to improve the outcomes. And of course, we have Dr. Patel with his reverse panel, and whatever number of times you listen to him, it is never ever adequate. So you always find something new coming in, and I think time and again it is something which has to be repeated over and over again so that it gets into our muscle memory as to how to protect ourselves and how to conduct ourselves so that we don't get into medical legal litigations. So it is indeed a great pleasure, and thank you so much for having me here. And I wish the webinar all the best. Thank you so much.
Thank you, Manju Puri madam, for sparing time to bless us. Of course, you are always with us. Whenever we have called you, you have always said yes. Thank you for sparing time.
Thank you so much, Manju ma'am.
So all the best to
So
all those
Dr.
who are, thank you. Yeah, all the best to all those who are contesting this time. So my best wishes to everyone. Yeah, thanks.
Thank you,
madam.
ma'am.
Thank you.
Thank you, ma'am. Thank you so much. Ma'am, sir, Dr.Asmita Rathore ma'am has not joined in.
Yeah.
So no, we can proceed accordingly. If she joins, we can have blessings from her at that time.
Okay. Okay, sir. So, ma'am is the former director and professor and HOD obstetric gynae at MAMC Delhi, and a very well-decorated gynecologist. Now, I request Rekha ma'am to introduce our three chairpersons, and then requesting one of the chairpersons to introduce the speaker, the second one to actually introduce the topic, and the third one to sum up. So requesting you, ma'am, would you please go ahead?
Yeah. Thank you so much. And again, have the opportunity of introducing one of my good friends, Dr. Professor Mala Srivastav, madam. She's head of Gynecology Oncology Unit, senior consultant and professor from GRIP MER, Gynec Endoscopic and Robotic Surgeon.
I'm sorry to interrupt you, Dr. Rekha.
Yeah.
Dr. Asmita has joined.
Okay, sorry. Yeah.
So,
I could not see that.
I'm sorry to interrupt you. She sent a message that she has joined. So I'll read out her CV and we'll take her blessings and then we'll take the program forward.
Fine.
So ma'am is the medical director, GTB Hospital and UCMS Delhi. Former director, professor and HOD, obstetric gynae, MAMC Delhi. Her areas of interest are maternal fetal medicine. She is a faculty fellowship in MFM, maternal fetal medicine. Has 50 publications, 30 chapters, edited 5 books. She's a member of expert panel UPSC, NBEMS, GNCT, Government of India. Has the Foxy Bhira Award and Dr. Leela Dubey Oration to her credit. And she has professionally affiliated to AICC RCOG Newsed North Zone Fellow Representative, AOGD President 22-23, NACHI Delhi President 22-22, and IG Executive Committee Member 22-23. So, requesting you to please join my, share your thoughts, ma'am. Asmita, ma'am?
Can you see her?
I think she has joined in the wrong link and she's not picking up my call. That is the whole
Delegates
issue.
link she might have joined.
Let me try. Let me try.
She has joined from the delegate link.
Yeah.
So you will have to promote her
Or send
Sir,
the
I cannot.
faculty link.
from delegate to faculty.
No, instead of that, call her
Cannot-
and tell her
cannot,
to
sir.
join through the faculty link, no?
Yeah,
Or one option we can give, she will have to log out from delegate link and from faculty link
Yes.
she may join again.
Yes, sir. That's what we are saying.
Dr. Rekha, when she joins,
She is joining,
we'll
madam,
take
in a
her
while.
blessings.
Yeah, she's joining in a while.
Yeah, so till then we continue with the
Please,
program.
please, please.
So
Yeah.
over to you, Dr. Rekha.
Yeah, fine. Thank you. Professor Mala Srivastav, Madam is Head of Gynec Oncology, Unit Shri Gangaram Hospital. She has been the President of NARCHI Delhi Chapter 2024 to 26. And she's the Vice President of ISOPARP 2020-24, past President of Association of Obstetrics and Gynecology Delhi 20 to 21. Her areas of interest are gynec oncology, gynec endoscopic surgery, as well as robotic surgeries. She's the fellow of special training is fellow of minimal access surgery, and she has been trained in robotic surgery from France. She has lot of awards to her credit and lot of important positions in her illustrious academic career. Dr. Mala, welcome, and please chair this session. And I will move on to the next chairperson, if you do not mind. We are inviting you here, Dr. Mala.
Good evening, everyone.
Yeah. Yeah, thank you. Again, it is a proud task to introduce Dr. Renu Chawla, another chairperson here. Madam is the senior consultant in obstetrics gynecology from Kailash Deepak Hospital. She's a graduate as well as a PG from LHMC SSK Hospital, and she's a past joint secretary of EDGF. She's a recipient of APJ Abdul Kalam Appreciation Award. She's in practice for more than 3 decades. Her interest is in high-risk obstetrics. Madam, you are the right person to chair this session. Again, we are happy to have you. Renu Chawla.
She's joined for a while. She didn't have faculty link. I have just sent her. She's joining.
Thank you.
Yeah, she has joined.
Dr. Chanda, madam, is a
Thank you.
obstetrician
Thank you, ma'am.
gynecologist. Yeah, thank you. From the Acharya Shri Bhikshu Government Hospital, Moti Nagar, New Delhi, President DGF North Wing, ex-president of Vice President DGF North Wing from 2020 to 22. She's from Lady Hardinge Medical College, DNB Guide and Assessor of DNB exams, Nodal Officer of ABCH, and her special interests are in high-risk pregnancy, fertility, as well as endoscopic surgery. Madam has been the recipient of APJ Abdul Kalam Excellence Award and recipient of the same appreciation award also. Again, welcome Dr. Renu Manchanda, madam. Requesting all 3 chairpersons to chair the session and take the proceedings. Dr. Shakuntala, madam, is going to speak on chronic pelvic pain.
Good
Over to
evening, everyone.
chairpersons. Yeah.
Good evening, everyone. It's my pleasure and privilege to introduce the star speaker of the evening, none other than Dr. Shakuntala Kumar. Dr. Shakuntala Kumar has MD New Life Chain of Hospitals. She's a Secretary IMA DNG 2024-25, Co-Chairperson of PGD MLC, Scientific Advisor DGF North, past Chairperson Adolescent Committee of AOGD, Executive Member of Adolescent Committee of AOGD, ex-Joint Director Delhi ISAR, ex-Treasurer ISPAT Delhi Chapter, recipient of President Abdul Kalam Award and around 15 publications to credit. And we all know her as a very active administrator as well as academician. And we are all looking forward for your scientific deliberation. Over to you, Dr. Shakuntala, for your topic.
Thank you, Madam Mala, for your kind introduction. I'll just share my slides. Can you please stop sharing? How do I am just a second.
I've already made you co-host, Dr. Shakuntala.
All right.
Should not be a problem.
How do I share my slides? I am not able to share.
Ma'am, your presentation is on your mail. You need to save that first. Save that in your laptop. Yes.
It is already saved, actually, ma'am.
Yeah, it's there now. You just have to make
it's already
it
there, but आपको slide show करना है बस. It's already there.
Yeah.
It's already visible. इसको slide show पे डालना है बस.
Make it full screen.
Yeah. Just a second, sir. Just a second. Now, can you see my slides, please?
Yes, we can see your slides.
So much. Thank you so much. Thank you so much, Madam Mala, for your kind introduction. I'll be speaking on a very pertinent topic, that is chronic pelvic pain, which is like every day in and day out we are dealing with. And we sometimes are in a dilemma whether it is the pain arising from the pelvic organs, or is it a referred pain or something radiating from somewhere else. To look at the definition, it is persistent non-cyclic pain which is perceived to be in the structures which are related to the pelvis, which may not necessarily be the reproductive organs. And then the definition is that it has to last more than 6 months. Chronic pelvic pain should be considered a symptom rather than a diagnosis, and there is debate as to what the precise definition should be. However, the recent European guidelines recognize a more encompassing view of chronic pelvic pain and say that it is perceived to arise from structures often associated with negative cognitive, behavioral, sexual, and emotional consequences, as well as with symptoms suggestive of lower urinary tract, sexual, bowel, pelvic floor, or gynecological dysfunction. It has been an enigma. 20 years ago, I would have told you that I knew everything there was to know about pelvic pain. 10 years ago, I would have told you that no one knew anything about this pain. Today, I can tell you that we have learned a lot in the past few years, but there is still a great deal that needs to be learned. Whenever a woman with chronic pelvic pain reports, she would report a lower quality of life with high rates of functional impairment, psychosocial distress, sexual dysfunction, and definitely the economic cost which is associated with it is enormous, not only to the healthcare system, but as well as to the society. They are often prescribed inappropriate analgesics such as opioids, and sometimes they are given antidepressants and anti-anxiety agents as well. These are the experiences of the women who are living with this symptom. They are embarrassed. They know that there is pain, but they are shy to share it. And they also need to know what is causing so much of pain. Well, there are 4 key themes that have been identified that are important for women with chronic pelvic pain. Number 1, to receive personal care by a supportive and understanding the healthcare team, to be taken seriously as a patient with genuine pain rather than a psychosomatic pain, to be given an explanation as much as a cure. I mean, deep counseling is required, and understanding of the pathology is required, and to be reassured that this pain is not caused by cancer, because that is the fear these women are living with. A systematic review of high quality studies by the World Health Organization in 2006 found the prevalence to range from approximately 2.1 to 24% of for the non-cyclical pain, 8% to 21% for dyspareunia, and 16% to 81% for dysmenorrhea. The updated review, which was published in 2014, used a more stringent definition, that is non-cyclical pain lasting at least 6 months, and then they found a prevalence of about 5.72 as varied as 26%. The causes can be that contribute to chronic pelvic pain can be gynecological causes or related to other organs. The gynecological causes can be as varied as endometriosis to ovarian remnant syndrome, trapped ovary syndrome. It can be vulval or vaginal pain syndrome, pelvic congestion syndrome, benign tumors. We'll come to it a little bit later. Gastrointestinal symptoms can be as mild as constipation lasting chronically. So chronic constipation can be a cause, irritable bowel syndrome, inflammatory bowel disease, diverticulitis and diverticulosis, chronic appendicitis and Meckel's diverticulum and adhesions. Urological syndromes can be because of pelvic pain syndrome, or urethral pain syndrome, or neuromuscular because of, which are the neuromuscular can be pain coming from the parietes or deeper organs. So it could be because of the trauma or surgery, or because of vaginal birthing leading on to coccygeal pain, piriformis syndrome, myofascial pain syndrome, etc. Psychological pain can be, the chronic pelvic pain can be because of depression, anxiety, history of sexual abuse. But if we are allocating it to depression and anxiety, we have to rule out all the other causes of chronic pelvic syndrome. Coming to pelvic congestion syndrome, it is basically associated with pelvic varicosities that result in chronic pelvic pain, because this is because of, of a setting of prolonged standing, coitus, menstruation, pregnancy. It typically affects a multiparous woman, and most women will present with non-cyclic lower abdominal or pelvic pain, which may persist for 4 to 6 months, often exacerbated by prolonged standing, coitus, menstruation, and pregnancy, as I told you earlier. And is the associated symptoms that are there with it are non-specific. There can be, headache, bloating, nausea, vaginal discharge, vulval swelling, feeling of leg fullness. So if a woman is coming with certain vulvovaginal symptoms of discharge, swelling, and non-specific symptoms, we have to look for this cause. This is an ultrasound finding of varicosities in the pelvis. This is basically CT scan, contrast enhanced CT scan, wherein you can see the pelvic congestion syndrome. And this is a cross section in the formatted 3D setting. So when we talk about the components, there are 4 key components that we need to address when we are, looking at the chronic pelvic pain. The pain which is arising from the end organs, that is the pelvic and the lower abdominal area. The musculoskeletal response to this particular pain, or if the pain is arising from musculoskeletal system, then the central sensitization of the nervous system and psychosocial consequences of this persistent pain. So, as Madam Manju Puri said, we require a multidisciplinary approach to diagnosis, investigation, and management of this particular condition. It aims to consider possibility of many etiologies that may be producing pain and subsequent sequelae such as low mood, emotional, behavioral, and sexual consequences. If a woman localizes her pain to the pelvis, it should not be immediately assumed that the pain is always and always gynecological. And if a woman continually presents with pain and a cause has not been identified, very important thing is that you have to consider a new or undetected underlying organic cause. The first priority would be to understand the pain that the woman is experiencing and how it is affecting her life. So, when you are considering a pelvic pain syndrome, please rule out the red flag conditions which require urgent intervention and sometimes surgical intervention. We'll come to it a little bit later. So, you have to determine if a specific etiology is causing the pain. Provide education and advice to enable this woman to begin and understand self-management of the pain. Initiate general management strategies, including lifestyle changes if that are required, and appropriate analgesia is very important because analgesics have their own side effects. And if further any investigations and management are required, please refer. So, a very comprehensive history is important. Look for the pain, history of pain, how long it has lasted, menstrual cycle, association with it, bowel and bladder function, sexual function, and any history of abuse. Please be discreet about asking for this history. What is the level of functioning, whether it is being hampered by the chronic pelvic pain, any comorbidities are associated, or any medications that the woman may be taking and you have probably failed to elicit. So the mnemonic for the pain would be Socrates: the site, the onset, the character, the radiation, the association, the time course, exacerbating relieving factors, and the severity. What is the onset of this pain, and if there has been an association of prior childbirth, surgery, any pregnancy related pain, whether it is musculoskeletal pain, what is the character? So if you look at the visceral pain, it will be dull and diffuse, but if there is any neural entrapment pain, it will be just like a shock. Radiation, if it is pain coming from the cervix or vagina, it will be radiating the back or buttocks. If it is pain from the ovary or fallopian tube, it is in the medial thigh. If there is any association, with the pain, like for example, menstruation, intercourse, urination, defecation is aggravating, or, if defecation and urination is relieving the pain. So a triad of sexual intercourse, menstruation, and defecation is characteristic of endometriosis. We'll all know about it. Now, time course, if there is any cyclical pattern, well, endometriosis pain is typically, several days prior to menstruation. It starts happening and then gets aggravated, continues for the first day or two of menstruation. Pain that is worse at the end of the day and related to posture could be because of pelvic congestion or musculoskeletal. If there are any exacerbating and relieving factors, then if the woman is taking any medicines or alternative remedies that may relieve the pain or life events, if there are any sleep disruptions, depression, anxiety, or stress, which may worsen the pain, or if there is any severity, anything that is, varying chronic pain which is coming over the time. So a monthly pain diary is very important. Ask the woman to maintain a monthly diary. This is what a pain diary would look like. When the patient is pain-free, if she has minor pain starting from score 1 to 3, moderate pain score 4 to 6, and severe pain up to 7 to 10. In this daily pain diary, look for the, what is the pain, as it could be, if it is, what is the date of the pain, time, where is the pain, and so on and so forth. So maintain a pain diary. This is an International Pelvic Pain Society assessment form. It basically guides and helps us in assessing the pain assessment form. If it is needed, I'll just share it in the group. The menstrual cycle. When we are talking about the menstrual cycle, whether the periods are regular, heavy, light, if they are associated with pain. For example, if there is adenomyosis or uterine leiomyoma, it may cause heavy menstrual periods, So pain would be associated with heavy periods, and the periods, will be painful. Cyclical pelvic pain is usually hormonally driven, although other conditions may also worsen around menstruation. For example, if the woman is having IBS or bladder pain syndrome, they may get aggravated and may look like cyclical pelvic pain. Look at the bowel function of the woman. If she has any history of chronic constipation, diarrhea, bloating, and if there is any relationship of this gastrointestinal symptom to the pain, diet, stress, menstrual cycle, or if there are any weight changes in the woman. Now, constipation is something we have to really look into and talk about it with the woman in detail. The bladder functions, we have to rule out recurrent urinary tract infection. Now, if there is, a pain which is relieved by micturition, or if it gets worsened, that is what that we have to look into. Sexual history, if any sexual abuse is there. Chronic pelvic pain, if a woman is having on the woman's sexual relationship, then, if it is causing any additional stress, low self-esteem, or sexual confidence is lowered, that history is to be looked into. What is the level of functioning? How is this pain affecting the woman's life? Are there any activities that she is avoiding during this pain? Is she employed? She required time off work? It's like a woman suffering from gradually increasing pain, taking off from work. Please get alerted and look into the causes of pain and talk about it. And definitely you have to look for her exercise, caffeine, alcohol, smoking status, relationships, social support, stresses, and what are the coping mechanisms that she's taking to combat this pain. Any comorbidities that are associated are to be looked into, and also look for her sleep, fatigue, appetite, mood, and social isolation. Any medication that she is on, that is to be considered and then talked about, because sometimes women forget to narrate the simple medications that they may be taking. And if on physical examination, you have to look for something, then you please look for those dermatomes for pain, the tissues, nerves, muscles, and organs that can reproduce the patient's pain syndrome in symptom in an attempt to determine the underlying cause. So the referred pain has to be looked into. Well, if you ask the woman to raise her leg or raise her head and then see for the pain, and if you do a deep palpation, and if the pain is aggravated, then the pain is coming from the parietes. If the pain is not so much aggravated, then it is probably a visceral pain. So this is the Carnet's test for patient with chronic pelvic pain. Look for the diagnostic testing that is required. So they may not be very much of value in a woman who's suffering from chronic pelvic pain, but it is important to rule out other causes, other causes of pain, which may be mimicking the chronic pelvic pain. Please go for a complete blood count with differential erythrocyte sedimentation rate, a urine analysis, a chlamydia and gonorrhea testing, a pregnancy test to rule out or screen for a chronic infection or inflammatory process, or to rule out pregnancy. Then a transvaginal sonography is basically important to look for any lump which is less than 4 centimeters size, which may be missed out on a bimanual examination. Also, if you have to detect hydrosalpinx, then transvaginal sonography is of much help. Magnetic resonance imaging, it has to be considered only when you are suspecting adenomyosis as a pelvic pathology, but the role of magnetic resonance imaging is limited in its ability to detect endometriotic deposits, especially if they are minuscule deposits. When the pain is severe, the patient should be referred for laparoscopy. However, laparoscopy is negative in nearly 40% of cases. We must remember then in that case. And if you are doing laparoscopy in an awake patient, and then you have to, what we do is we probe those tissues, we pull them, and then look for the symptoms. If ask the patient about the severity and nature of any pain that she is perceiving while we are doing an awake laparoscopy. So these are few pictures of severe PID adhesions. These are severe adhesions causing the chronic pelvic congestion and pain. And this is a chronic PID, a lady with chronic PID with suppuration leading to chronic pelvic pain. These are subtle endometriotic spots. They can cause severe pain or they may not cause any symptom to begin with. What are the some clues which may help us? So if the pain is crampy, it may be because of IBS or IBD. If the pain is like electrical shock, it could be because of nerve entrapment. If it is fluctuating with menstrual cycle, endometriosis, adenomyosis. If it is unassociated with menstrual cycle, it could be because of adhesion, interstitial cystitis, IBS, or musculoskeletal etiology. If there is any pain because of urge to void, consider cystitis or urethral syndrome. Postcoital bleeding, cervical malignancy. Postmenopausal bleeding, considers endometrial malignancy, or if there is any postmenopausal onset of pain or bleeding, consider malignancy in mind. If there is any abdominal surgery or infection, that, because of adhesions, the pain is probably because of adhesions. If there is an unexplained weight loss along with pain, consider malignancy or any systematic illness. Clinical clues like adnexal masses can be because of ovarian neoplasms. On physical examination, if there is any enlarged or tender uterus, consider endometritis or adenomyosis. These are the lists, which would help us in finding out the particular cause of pain. If there is any pelvic floor tenderness, interstitial cystitis, point tenderness of vagina, vulva, or bladder could be because of adhesions, endometriosis, or nerve entrapment. If there is any positive carnate side, as I said earlier, it could be because of abdominal wart source. If there is a suburethral mass, it could be because of diverticulum. Uterosacral ligament abnormality can be pointing towards endometriosis, adenomyosis, or malignancy. If there is any vulvar or vestibular pain, it could be solely because of vulvodynia. On diagnostic testing, if you see microscopic hematuria or gross hematuria, it could be because of interstitial cystitis or urinary system malignancy. If there is painless hematuria, please go for cystoscopy and rule out any lump in the bladder. Mass on ultrasonography, we should rule out malignancy. What are the red flag signs that we have to rule out? These symptoms and signs are rectal bleeding, irregular vaginal bleeding, postcoital bleeding, onset of a new bowel symptom in a woman who's more than 50, excessive or unexplained weight loss, onset of pelvic pain or pelvic mass. So these are the signs which require urgent intervention, and you have to forget the chronicity of the pelvic pain and go on and investigate and rule out any serious sign or symptom of a disease. So friends, to look at the evaluation of chronic pelvic pain, you have a patient who's presenting with the pain, you go for history, physical examination, rule out the red flag findings. If there are none, go for, basic testing. If all the tests are normal, refer for laparoscopy. Again, if it is normal, then manage this woman as chronic pelvic pain syndrome. So the goal of treatment, the last few slides are left, is to maximize this patient's quality of life. Evidence-based therapy remains limited and is often focused on symptom relief. Any obvious disease process must be treated, even though targeted treatment may not result in resolution of pain. And you have to ask this woman to manage her pain by lifestyle modification and certain other methodologies of pain relief. The cause and consequences of pain can involve multiple mechanisms. So it has to be a holistic approach which would address her physical, behavioral, psychological, and sexual components. The medications should address the underlying cause of pelvic pain. If the cause is not known, then pharmacological therapy will be aimed at symptomatic relief. These analgesics, simple analgesics like acetaminophen and NSAIDs are usually well tolerated, but a Cochrane review concluded that NSAIDs are not effective for treating chronic pelvic pain associated with endometriosis. There are evidences to prove that oral contraceptive is definitely effective in dysmenorrhea, which is associated with endometriosis. However, the pain relief may be felt after 3 to 6 cycles. So the patient should be counseled accordingly. Then, if the patient has endometriosis, you may consider medications like goserelin. They provide long-lasting effect compared to depomedroxyprogesterone. The levonorgestrel intrauterine system has been shown to reduce recurrence of dysmenorrhea if it is placed after laparoscopic treatment of endometriosis, and you have ruled out all other causes. However, in women who have pain of unknown etiology, it has only short-term relief, low satisfaction because of adverse effects of progesterone causing bloating sensation and probably increased congestion. If you suspect neuropathic pain, then consider giving tricyclic antidepressants and serotonin, norepinephrine reuptake inhibitors, or maybe anticonvulsants or pregabalin. They may be helpful in certain selected population. Although data regarding their effectiveness in treating chronic pelvic pain are limited, there is evidence of benefit for treating neuropathic pain in general. A Cochrane review of tricyclic antidepressants for the treatment of neuropathic pain concluded that they are effective. Gabapentin provides good relief of neuropathic pain, and a study of chronic pelvic pain in women suggested that it used alone in combination with amitriptyline is more effective than amitriptyline alone. Opioids, the use has to be very limited and it has to be guarded. You have to give it in patients, in a selected number of patients only, and if the cause is terminal malignancy, then maybe they may be considered in liberal amount. So these are the various agents and the pain types and the various comments that I have just added just to sum up the medications which are used to treat non-specific chronic pelvic pain. Surgical intervention to relieve pain is often limited, but pain is likely to improve after laparoscopic surgery to treat endometriosis and adhesiolysis. Hysterectomy may be a last resort because of high morbidity and its limited benefits. In young women, consider all other modalities before resorting to hysterectomy. About one half of women with uterine tenderness on pelvic examination have shown improvement in mental health, physical health, and social functioning after hysterectomy, especially if they are around in their 50s or in their late 40s. However, up to 40% will have persistent pain and at least 5% will have worse pain. So please consider hysterectomy very, very carefully. Local injection of steroids may be therapeutic as well as diagnostic when peripheral pain nerves are involved. If there is sacral nerve involvement, pain relief may be possible with sacral nerve block or neuromodulation by means of a surgically implanted device which stimulates the nerve with electric pulses. Studies are ongoing to investigate the specific role of these modalities in the treatment of chronic pelvic pain. Physical therapy, well, its proponents cite benefits for diagnosis and treatment. Referral should be considered when there is pelvic floor tenderness. Multiple small studies support use of biofeedback for chronic pelvic pain. It helps patients recognize the action of pelvic floor muscles and has been shown to provide better pain relief. Behavioral interventions, very important. They need a lot of support, cognitive psychotherapy, the somatocognitive therapy, and this will help in improve their distress, pain experience, and motor function. Monitoring of these patients is important to reduce symptoms and improve their quality of life. Monitoring of their mood, pain, and frequent follow-ups are required. A numeric pain scale would help quantify and measure any change in their pain. And if the severity increases or they go into depression or they have pain, alteration, which is like beyond their, control, then you have to rule out and find out a fresh organic cause. So finally, this is the algorithm of the management of chronic pelvic pain. I have described all the points here. And the most important point is to primary care, secondary care, and primary and secondary care combined. So first 4 to 12 weeks, you have to look for the primary care by diagnosing, by detailed history examination, refer to other specialties like gastro or uro if you consider that they are the causes, and treatment has to be started. In 6 weeks to 6 months, look for the gynecological causes, and if there is no response to treatment, treatment should start on in the form of oral contraceptive pill, antibiotic, and dietary advice. And if you feel that 12 to 18 weeks have passed and there is no response to treatment, please do not wait any further and consider things and modalities like referral to other departments if the patient is not improving, or going for diagnostic laparoscopy. If there is no cause identified, then go on to other modalities beyond 18 weeks. You have to refer back to general practice. You have to manage the chronic pelvic pain, go for physiotherapy, cognitive behavioral therapy, pharmacological interventions. Do not stop there and treat the patient. That is very important. So the key recommendations, friends and my dear seniors, in the absence of a clear etiology, chronic pelvic pain should be considered a regional pain syndrome or functional somatic syndrome, and biosocial approach to the care is indicated. In patients with chronic pelvic pain, you have to rule out red flag findings. When chronic pelvic pain is severe, the patient should be referred for laparoscopy. Limited evidence supports the use of non-steroidal anti-inflammatory drugs, tricyclic antidepressants, the Neurontin like gabapentin and serotonin norepinephrine reuptake inhibitors for the treatment of these symptoms. I thank you for your patient listening. And I really wish all the best to all the contestants. And my sincere thanks to our Dr. M.C. Patel, sir.
Thank you, Shakuntala.
Thanks, Dr. Shakuntala. That was a nice deliberation on chronic pelvic pain. We know chronic pelvic pain is really troublesome for the woman who suffers, and very important to take the proper history, do a proper examination, and of course, relevant investigations. We have to understand that there may be other than gynecological causes of chronic pelvic pain. We have to rule out bladder problems, bowel problems, as well as referred pain. And we all understand that chronic pelvic pain affects not only the quality of life of the woman, but also her relationship, sexual function, and it may lead to also social isolation. So counseling is important, correct diagnosis is important, medications is important, and sometimes we have to help this women out by doing surgical intervention. You have really guided us when to do what, primary, secondary, and tertiary evaluation of these patients and treatment. Thanks, Dr. Shakuntala, for your nice and elaborate scientific deliberation on this particular topic.
Thank you, ma'am.
Renu Chawla, madam, you have anything to say? Dr. Shakuntala, it was a very nice deliberation. You have covered almost everything about the chronic pelvic pain. But I just want to say one thing, that there may be residual ovarian syndrome, which we need to consider also. Almost all the things you have covered. So in these cases, we have to rule out the hormonal levels, which will help us in finding out that whether it is a postmenopausal thing or the ovarian tissue has been left in the patients who have undergone hysterectomy and bilateral salpingo-oophorectomy. Rest all you have covered very nicely, and you have guided us at each and every step, that initially what we should do, first step, second step, and third step. And I think we are better off now, more knowledgeable for treating our patients of chronic pelvic pain. Thank you so much, Dr. Shakuntala.
Thank you, ma'am.
Renu Manchanda, ma'am, would you like to say something?
Yeah, first I wish to convey my sincere thanks to Dr. Patel and Dr. Achla for having me here. And the topic today is very relevant, as we have many patients in our gynae practice who come with chronic pelvic pain, and because they are not relieved, we do not take it very seriously. And sometimes we take it as a psychosomatic lesion. But I just want to emphasize that this symptom of chronic pelvic pain has a lot of psychosocial, economic, and sexual impact. And so we have to take the symptoms seriously and evaluate the causes of these, like gynecological causes. In my experience, mostly these women have endometriosis or pelvic lesions or adenomyosis. So we have to rule out, as Dr. Shakuntala has already covered the topic in a very comprehensive way, and I congratulate her for that. It requires detailed evaluation. We should be very clear about the red flag signs which she has talked about, and rule out malignancy if there are any red flag signs early in our evaluation, and referral to other departments, like if there are bowel symptoms, bladder, that also is required. And management of pain, relief of pain. I think symptoms is very important because it causes a lot of anxiety and depression in this woman. So relief of pain and treatment of the underlying cause, if we find any, all this thing will go a long way in helping these patients who are suffering a lot because of their pain for a long duration of time. Thank you so much for having me here.
Thank you, Renu and Chawla, madam.
Thank you so much, ma'am. Thank you, chairpersons, and thank you, Dr. Shakuntala. That was a very difficult but very well elaborated presentation. Thank you so much. Now, I would like to introduce the chairpersons of the second session. We have Dr. Harsha Khullar, ma'am, who's a senior consultant and is currently at the Institute of Obstetrics and Gynaecology, Sri Gangaram Hospital, New Delhi. Her special interest is oncology. I met her first in Association of Gynaecologists Committee conferences. Welcome, Dr. Harsha. She is the President North Zone ISOPAP, President Delhi Gynec Forum Central, past President ISOPAP Delhi Branch, ex-member of Foxy Breast Committee, past VP Narchi, Delhi Branch, Secretary AOGD, has been awarded APJ Abdul Kalam Appreciation Award by DGF. So welcome, Harsha ma'am. We have, I hope you remember me.
Yes, ma'am. Yes, I remember you.
So ma'am, our other two chairpersons are Dr. Renu Mishra ma'am, who's the Director of Kamna Fertility and IVF, Senior Consultant at Sitaram Bhartiya Institute of Science, Delhi, Additional Professor at AIIMS, New Delhi previously. Her areas of interest are endoscopic surgery and fertility. IVF, has many, many awards and was the past editor of Indian Journal of Gynec Endoscopy. We have Dr. Punita Mahajan ma'am, who is presently working as consultant gynae at Ambedkar Medical College and Hospital. She's served the North Zone from 2015 to May 18. She's a graduate of Lady Hardinge Medical College and PG from Safdarjung. She has state awards and many more awards. So requesting Harsha ma'am, if you would please introduce our speaker, Dr. Shashi L. Kabra Maheshwari ma'am.
Sure, ma'am. Thank you very much for your kind words, ma'am, about my introduction. Now I'm going to
please
introduce...
put on your, please open your video if possible. Yes, ma'am.
Anji.
We would love to see you as well.
Oh.
Ma'am, please start your video.
Yes, I'm just doing. Yes. Yes. Now you can see me, I think.
Yes. So happy to see you.
Yes, ma'am. Yes.
So it's my proud privilege to introduce Dr. Shashi Lata Kabra Maheshwari. She is MD FICOG FMES Diploma in MAS. And she is the IMA she has received IMA Appreciation Award 2018, recipient of Wonder Foxy Award 2019, APJ Abdul Kalam Appreciation Award 2020, IMA WDW Karanveer Award 2021. There are so many, I think, feathers in her cap that I'll have to take too much of time to tell all this. She has organized 85 workshops. She has been mentor for the Lakshya Government of India, member Practical Obstetric Committee, Foxy, North Zone Coordinator. So, Dr. Shashi, I think you are going to speak on the maternal sepsis. So, we would like to hear about your talk. Dr. Shashi, please.
Thank you so much, Harsha ma'am, for your kind introduction. Sharing my slides. Thank you, M.C.Patel sir, Dr. Rekha Rajendrakumar ma'am, Dr. Asha Jain for having me here. And thanks to all my chairpersons. I think my slide is visible.
Yes.
Yeah. So I'm talking about one of the important cause of maternal deaths in Indian women and also in Western world, and it is little untouched. And I thank especially for giving me this topic. So this is a life-threatening condition as described by WHO, which is defined as organ dysfunction resulting from infection during pregnancy, childbirth, post-abortion, and postpartum period. All four periods are very important. And the commonest cause of maternal mortality worldwide is postpartum hemorrhage, 27%. Then hypertensive disease of pregnancy, 14%. And just see, sepsis is the third commonest cause of maternal death, contributing to 11% of maternal deaths. We talk a lot about postpartum hemorrhage. We talk a lot about hypertensive disease of pregnancy, but somehow this sepsis is discussed less. And unfortunately, the incidence is rising even in Western world. It is a highly lethal condition as without prompt recognition and appropriate treatment, it can quickly cause death. And the nature is very rapidly progressive, and that makes it challenging to treat, especially in low resource settings. And both the antepartum and postpartum and interpartum maternal sepsis, even if they are treated, they lead to long-term morbidity, neonatal sepsis, preterm birth, admission to NICU, and increased perinatal mortality rate. This is one of the statistics. Every 4 minutes, a woman dies from sepsis-related cause somewhere in the world, with the greatest burden borne by the women in low and middle-income countries. Maternal infection and sepsis can be eliminated with good hygiene and infection control practices and prompt recognition. It is the word that is prompt recognition and treatment of these conditions. Unless we know the treatment, but if we fail to recognize, then the treatment will be delayed. So these are shared by WHO. Like in pregnancy, 6 weeks postnatal, during childbirth, and post-abortion, we should always look for warning signs, and we should be aware and alert. And these are few practices like practice clean care, diagnose early, and treat promptly. These are the key points for treating maternal sepsis. So today I will talk about evidence-based management of maternal sepsis, which is really an evolving challenge. So these are the common signs: fever and rigors. Even only a history of mild fever is very important. Then diarrhea and vomiting. Sometimes we ignore diarrhea and vomiting if it is mild. So we should not ignore that thing. We should correlate it with patient's pulse and temperature, everything. Then rash, abdominal pelvic pain or tenderness, any offensive vaginal discharge, smelly such as anaerobes, and sarosanguinous as a streptococcal infection. So whenever a patient is we are suspecting sepsis in any patient, we must perform a PV examination to look for the character of the discharge. Then the patient can have sepsis with some lung involvement. So we have to look for cough and auscultate chest. And recently, I've been seeing many patients of maternal sepsis with urinary symptoms and UTI. So as per Society for Maternal Fetal Medicine, the common obstetrical cause is septic abortion. We get a lot of patients with history of empty pill intake outside without any doctor's prescription and then are admitting to our hospital with septic abortion. Then chorioamnitis in those especially who have history of premature rupture of membrane. Then postpartum endometritis and wound infection are the causes. And among the non-obstetrical causes, urinary tract infection is very common. We get a lot of cases of appendicitis and neglected appendicitis also. Besides this, pneumonia and gastrointestinal infections. Assisted reproductive techniques and multiple gestation increases the rate. It's a beautiful diagram. The commonest cause of sepsis is genitourinary infection in 40% of cases. And among the genitourinary infections, these are the common: Escherichia coli, then this one, Staphylococcus, Streptococcus. That's also known as Streptococcus pyogenes. It's a very bad infection. Then methicillin resistant staph aureus are very difficult to treat. Sepsis can affect any of the organs in central nervous system, altered mental status, cardiovascular system, hypertension, and third spacing, myocardial dysfunction. In pulmonary system, ARDS, There are two types of pulmonary edema. One is cardiogenic pulmonary edema, which happens due to overload, and this ARDS is due to sepsis. Then gastrointestinal system paralytic ileus, hepatic system, it may lead to hepatic failure, it may lead to oliguria, acute kidney injury, thrombocytopenia, or disseminated intravascular coagulopathy, and even some adrenal dysfunction. But in my hospital, I have seen all these, but this is little rare to occur. So how to diagnose? You have to remember four things: SIRS criteria, sepsis inflammatory response syndrome criteria. If there are four criteria, and if any two are positive, then we will suspect sepsis, and it has to be confirmed by localizing the focus of sepsis. What are these criteria? Temperature more than 100.4 degree Fahrenheit or less than 96 degree Fahrenheit. Then heart rate more than 90 beats per minute, respiratory rate more than 20 beats per minute, 20 beats per minute, and WBC either less than 4,000 per cubic mm or more than 12,000 per cubic mm. And there are two new things, bedside methods, Q-SOFA score and obstetrically modified SOFA score. They basically are assessed in advanced stage of sepsis, and it includes altered mentation criteria also. So what I want to say to those who are in the learning stage is that we do not assess. I heard from someone that they are doing Q-SOFA score every day on every patient, and this is how they are diagnosing sepsis. Q-SOFA score does not help us in diagnosing sepsis. It is too late when it occurs. So how to diagnose sepsis? By SIRS criteria. That is more important. The most difficult aspect of recognition of SIRS in pregnancy is the differentiation of the condition from the normal physiological changes of pregnancy with which it overlaps. Respiratory rate increases during pregnancy, heart rate increases during pregnancy, WBC increases during pregnancy, so sometimes it becomes difficult. And Q-SOFA score does not define sepsis, rather it is a rapid method of identifying those patients at high risk of developing severe complications who require more aggressive therapy. So our purpose is to recognize sepsis with SIRS criteria, not to wait till Q-SOFA score becomes positive. This is another obstetrically modified SOFA score. It is little elaborate, so cannot be remembered like this, but one can paste in their ICU, SDO labor rooms, like when PaO2 is, this grade has been given 0, 1, 2, then coagulation profile, platelet value, this, as the value decreases, the score increases, then bilirubin, then cardiovascular. I remember one patient had bilirubin 45, then mean arterial pressure. When the requirement of vasopressor occurs, then the score is 2, then renal and central nervous system. Now, Sepsis 3 campaign defines septic shock as sepsis associated with vasopressor requirement to maintain a mean arterial pressure of 65 millimeter of Hg in the absence of hypovolemia. If we have given fluid to the patient who is in septic shock and still it is not increasing, then we need to give vasopressor. Then it is septic shock. And remember one thing, when the patient is received in septic shock, the chances of mortality are already 30 to 40%. So it's better that we should not let the patient go into sepsis. Then serum lactate is found increase in these patients. But this particular investigation is not available everywhere. So this is the beautiful 1 hour bundle of the treatment of sepsis. We have suspected sepsis with the help of SIRS criteria. Now what? You have to localize a focus of sepsis. Then SIRS criteria plus focus makes it sepsis. So number 1, you measure lactate level. If this facility is not available, no problem. Make use of 2 hands together. From one side, you obtain blood for blood culture, and from another side, push the antibiotic. The antibiotic has to be given within 1 hour. I will tell you why. Then, administered broad spectrum antibiotic. Begin rapid administration of fluid at the rate of 30 ml per kg. Crystalloid is the fluid of choice, and that is Ringer's lactate for all practical purposes for hypotension. And then apply vasopressors if hypotensive during or after fluid resuscitation to maintain a mean arterial pressure of more than or equal to 65 millimeter of Hg. Such a simple criteria. Why? And if antibiotic treatment is delayed, then mortality increases by 7% with each hour delay. That means you are suspecting sepsis, but you are not giving antibiotic and delayed it for 5 hours. That means 5 7s are 35. We have already increased the incidence of mortality by 30 to 35%. So if even sepsis is suspected, please give antibiotic. There is no harm. A broad spectrum antibiotic. So these are the common investigations: complete blood count, We will get here hemoglobin and WBC. Peripheral blood smear, we can see toxic granules, liver function test, kidney function test, coagulation profile, and serum lactate if available. And we have to measure SpO2 also. It's a good sign for pulmonary edema, and pulse, temperature, respiration, BP charting. All these facilities are usually available in a hospital. Now, the indications for admission to ICU are cardiovascular condition, hypertension, suggesting the need for ionotop support, respiratory, pulmonary edema, mechanical ventilation, airway protection, if the patient requires dialysis, significantly decreased conscious level, and if the patient is in multi-organ failure. A patient of sepsis first have a single organ failure, and if left untreated or is getting the wrong treatment, then the patient goes in multi-organ failure. And once the patient goes into multi-organ failure, the percentage of death increases. So this is a table which shows the common broad-spectrum antibiotic coverage in sepsis complicating pregnancy. Like for community-acquired pneumonia, we can give third-generation cephalosporin. I can share my PPT, and those who want to take the screenshot can take it. Hospital-acquired pneumonia, we have to give beta-lactam antibiotic and MRSA coverage with vancomycin and linezolid. And this is a very common condition found in our hospitals. Then for chorioamnitis, MP plus Genta is good, or Clinda. Then for endomyometritis, we can give MP, Genta, metronidazole. For UTI, gentamicin or ampicillin. And even nitrofurantoin can be given. And in resistant cases, we can give carbapenem, piptaz. Then abdominal infection, third generation cephalosporin. And for skin and soft tissue infection, we give vancomycin. This has been taken from Society of Maternal Fetal Medicine 2023. It's a very interesting slide. Coamoxiclav does not cover MRSA, methicillin-resistant staph aureus, which is a very common problem associated with nosocomial infection. Then metronidazole only covers anaerobes. So Clinda is a better medicine. Clinda covers both the anaerobes and also little MRSA, many MRSA. So then we have to quickly change over to this in those conditions which are not responding in 24 hours. Then peptaz, it covers all organisms but not MRSA, and then gentamicin. Maternal complication of chorioamnitis are endometritis, bacteremia, hemorrhage, and death. And MRSA may be resistant to Clinda. So in those cases, we have to quickly add vancomycin or teicoplanin. We should wait for once we have started one broad spectrum antibiotic, wait for only 24 to 36 hours. If patient is not improving, change over to the next antibiotic. And then besides antibiotic cover, we have to evacuate the surgical focus. This can be evacuation of retained projects of conception, debridement of wound infection, percutaneous drainage of abscess, stent or percutaneous nephrostomy for obstructive pyelonephritis, delivery of fetus if chorioamnitis is suspected, and hysterectomy for myometrial necrosis. In my last 23 years of career in DDU hospital, I performed hysterectomy in 4 cases of sepsis because wherever I was pricking the uterus, it was showing pus. So this is a call-out algorithm for sepsis when such a patient is found in our wards, like early warning score, then alert the surgical team and senior nurse, assess airway, breathing, circulation, and CNS system, then give oxygen, intravenous access, fluid management, reassess, and refer to a critical care. Actually, a patient of full-blown sepsis is treated by a multidisciplinary team. So you should always be aware of the red flag signs like pyrexia, then sustained tachycardia, breathlessness, abdominal or chest pain, diarrhea, vomiting, uterine or renal angle tenderness. And one very simple thing, if a postpartum woman is found is looking generally unwell, or looking unduly anxious or distressed, please rule out sepsis. The presence of sepsis alone is not an immediate indication for delivery. The decision to deliver the fetus should be individualized and will depend on gestational age as well as on maternal and fetal conditions. And it should be reserved for the usual obstetric indications after stabilization of the women. And there is no evidence that delivery improves maternal outcomes. In chorioamnitis, definitely you have to terminate the pregnancy. In most cases, resuscitation that improves maternal hemodynamics will result in improved uteroplacental perfusion and therefore improved fetal condition. If the uterus is found to be the source of infection, delivery is indicated. And involvement of neonatology, anesthesiology, and critical care consultants is fundamental. RCOG says that during interpartum period, continuous electric fetal monitoring is recommended, and changes in CTG such as baseline variability acceleration must prompt assessment of maternal mean arterial pressure, hypoxia, and acidemia. About anesthesia, epidural and spinal anesthesia should be avoided in women with sepsis, and the general anesthetic will usually be required for cesarean sections. In most pregnant women, initial administration of 1 to 2 liters of prostacyclin is reasonable, and the patient who are fluid responsive should be identified prior to further fluid administration. This can be accomplished by using pulse pressure variation or passive leg raising. They will have a change in their pulse pressure if they are responsive to fluid. In hypertensive patients who are not fluid responsive or who are not candidates for further fluid resuscitation, like women who are already in pulmonary edema, vasopressor should be utilized to increase blood pressure. And the purpose of vasopressor is to constrict the pathologically dilated systemic circulation and maintain adequate perfusion. So, according to all current guidelines, norepinephrine is the first line vasopressor of choice. It has been studied in human pregnancy and used to maintain blood pressure with regional anesthesia at the time of cesarean delivery. And it is also safe for fetus. So, this is a chart shared by Society for Maternal Fetal Medicine, 2023, norepinephrine. It is alpha-1 and beta-1 adrenergic receptor agonist, and it is the first drug for septic shock. Then, if the patient requires a second drug, then we have the vasopressin as the choice. And then dovitamin. Epinephrine is not the drug of choice. So, this is the summary of vasoactive agent. Epinephrine, try to maintain BP, mean arterial pressure 65 millimeter. Consider invasive monitoring of arterial blood pressure. Consider initiating vasopressors peripherally. And if the patient is not responding with this, still MAP is inadequate, then consider adding vasopressin. And if cardiac function with persistent hyperperfusion is present, despite adequate volume status and blood pressure, then consider adding dovitamin. This is the chart which I myself made for the common patients of sepsis, which we encounter in our hospital. Sometimes, when we encounter such patients, we keep asking our colleagues, what is the dose of peptides, what is the dose of meropenem? So you can have a ready chart. Peptides, dose is 4.5 gram, 6 hourly. Renal dose, 2.5 gram, 6 hourly. Route is intravenous. It is a broad spectrum antibiotic. Then meropenem dose is in a 50 to 60 kg women, 1 gram, 8 hourly. If the patient has renal compromise, then 500 milligram. It is a broad spectrum antibiotic. Vancomycin, 1 gram in a well-built patient or 500 milligram in a 50 kg patient. It has a narrow spectrum, but it is very good for MRSA. Clindamycin, 300 to 900. If the women is around 50 to 60 kg, you can give 600 to 900 also. It is very good for covering anaerobic. At the same time, a few MRSA. Then teicoplanin, the dose is 6 milligram per kg. Usually, most of the patients do respond to these antibiotics. These are the pictures of these antibiotics. I've taken this picture from my own ICU only to give a visual impression that we will need these antibiotics when our patient is suffering from moderate to severe sepsis. This is peptides bottle, 4.5 gram. This is meropenem, 500 milligram. This is meropenem, 1 gram. Then this is vancomycin, 500, and vancomycin, 1 gram also. This is Clinda, teicoplanin, 400 milligram. Intravenous immunoglobulin is recommended for severe invasive streptococcal or streptophilococcal infection if other therapies have failed. So the World Sepsis Day is 2023 says that together we can end maternal sepsis. In nutshell, suspect sepsis with the SIRS criteria, give the 1 hour treatment, obtain culture, give broad spectrum antibiotic, give IV fluid. All these I have discussed. If the patient's mean arterial pressure is less than 65, give epinephrine. In few cases, we have to give hydrocortisone also if there is no response with epinephrine, and achieve early source control. Imaging facilities will help, like imaging for pulmonary edema, then for finding latent products of conception in the uterus. Then consider electrofetal monitoring and give steroids if the baby is premature and you need to deliver. Sometimes the patient may require early enteral feeding and DVT prophylaxis if a heavyweight woman. So the conclusion is sepsis continues to be a major cause of morbidity and mortality worldwide. Treatment during pregnancy should follow the same basic principles as in the non-pregnant population, including early recognition, fluid therapy, timely broad-spectrum antibiotic, and source control. That's very important. How many antibiotics you give, but if we cannot control the source, and it will not respond. Vasopressors, norepinephrine should be used when indicated during pregnancy, and in most cases, delivery should be guided by obstetrical indications. And in pregnancy, sepsis, particularly septic shock, is associated with an increased risk for preterm delivery, prolonged recovery, stillbirth, and maternal death. Thank you so much for patient hearing.
Thank you, ma'am. Over to chairpersons, please.
Thank you, Dr. Shashi. It was an excellent deliberation on maternal sepsis. I must say that you have covered each and every point. And just 2-3 practical points, I can tell that it's very important that first hour is the golden hour, and we have to treat the patient. We have to take all the cultures before starting the antibiotics. Secondly, that we have to see that what is the lactate level. Thirdly, that hydration is very, very important. And to start with, this should be the crystalloids, not the colloids.
Absolutely.
So these points, they are very, very important. And as you have beautifully shown in the diagram also, that both hands should be used. And from both the sides, the one side blood is being taken, one side you can start the drip and all, and oxygen should be ready. And it is just like. Second point is that you said that it is the first line target. In article should be less than 60/3. Can you hear?
Please unmute everyone except Dr. Harsha, ma'am.
Hello.
Please unmute, please. Dr. Harsha, ma'am is speaking.
Hello.
Yes, ma'am.
More is that sound has been used to identify. Can you please
everyone is requested to please unmute. Please mute yourself. Dr. Harsha ma'am is speaking.
So ultrasound has been used to identify the fluid responsiveness by measuring the diameter of the inferior vena cava. Yes, if it is 1.5 centimeters, that means fluid responsiveness it needs. And more than that 2 to 2.5 centimeters, that the patient. And you should take care that patient going edema. And more point I want to say that the early recognition and
Asha ma'am, please request everybody to stop talking. We are not able to hear Asha
Actually, it's only Dr. Renu Chawla ma'am, and I'm not able to mute her. That is the problem. It's Dr. Renu Chawla who's speaking.
Yes, ma'am.
So can I speak now?
Yeah, yes, ma'am. Yes, ma'am.
So, maternal sepsis is preventable by early recognition, apply 1 hour bundle, remove the septic focus, and surgical intervention to remove a necrotic infective tissue. We have already covered all these points. So this is just, I have to say, excellent deliberation, Dr. Shetty. And
thank you so much.
And I think we can say when they say that sepsis. Very much. Thank you.
Thank you, Harsha ma'am. Requesting somebody to please call Renu ma'am. If you can call her and ask her to, disconnect her audio. There. Unable to mute her. I don't know what she has done.
Ma'am, I'm calling her.
Okay.
So let's finish then. I think Dr. Shashi, you've covered everything and it was an excellent talk. Thank you so much. Dr. Renu Mishra, is she there?
Thank you so much, ma'am.
हाँ, Dr. Renu ने mute कर दिया.
Patel sir, are you ready now?
Yes, I am there.
So,
So,
sir, we
Asha, if
now,
you allow, can I say a few words?
yes,
Excellent.
please
I
go ahead.
am there.
Yeah.
Yes.
So still sir joins. I had made a mnemonic
Sir
for
has
sepsis.
already joined.
Yeah. I had made a mnemonic for sepsis. It is the word sepsis itself. The first star bundle. Are you able to hear me, Asha?
Yes.
Yeah. So I had shared in
Yes,
the
we are
same,
able to hear you.
I'm sharing with you. S is send cultures, blood culture and all the cultures. E means estimate ringer lactate or procalcitonin if facility is there. P is prophylaxis. You have to start antibiotics. You have to hit hard and hit fast, full dose. Another sepsis, starting, crystalloids. Then I, infusing vasopressors if your mean arterial pressure is not being maintained. And the last S is supportive therapy like oxygenation, steroids, and all that has been beautifully discussed by Dr. Shashi. So this is one sepsis mnemonic itself, it gives you reminder. You have to do all the, maneuvers in first hour itself. It may not be in the order, but you have to perform all of them. So you can remember by this mnemonic sepsis itself. Over to MC Patel, sir. Thank you.
Okay. Thank you. Thank you, Anita. Yes, Dr. Asha.
Yes, sir. So now we have Dr. M.C.Patel sir in the line of fire with respected panelists asking him questions. We will first try to cover the act with some situations, following which any panelist can ask any question. We have exactly 1 hour because 8:30 we have to end the session and it is now 7:30. So welcome, sir. I would like to introduce respected MC Patel, sir. He doesn't need an introduction, but it's a privilege to remind ourselves of his accomplishments. He is a consultant obstetrician, gynecologist, and medical legal counselor, VP Foxy 2018, organizing secretary AICOG 2017, chairperson ethics and medical legal committee Foxy 2011 to 13, Honorary Secretary SOGOG 22 to 24, Organizing Chairperson MMCon 2018, Honorary Member National Inspection and Monitoring Committee PNDT Act Government of India, Honorary Member State Supervisory Board PNDT Committee Gujarat, President Ahmedabad Obstetric Gynec Society, previously Honorary Member National Managing Body Indian Red Cross Society Headquarters, National President National Medicos Organization 2016 to 18, President IMA Ahmedabad 2007 to 8, Honorary Surgeon Indian Red Cross Eye Bank, and has collected more than 1,000 eye pairs, organizing Chairperson Vivekanand NMOCon 2013, and the President of Lions Club Ghatlodhya Ahmedabad 97 to 98. This is a CV that we can all read, but more than this, we all know him as our next door person for any medical legal help. He's consistent, he's approachable, and he has been helping. He stopped being the chairperson in 2013, but he has continued that medical legal work for the last 11 years. So we are really honored to have him here. And the voting is from 10 a.m. 1st August 24 to 5 p.m. 10th August 24. Please endorse Sir's candidature. I have been introduced. Now here is a short video from Sir.
Shubham karotu kalyanam Arogyam Sukha Sampadam.
Respected seniors and dear colleagues, serving Foxy for years together, on this auspicious day, with folded hands and down head, I seek your guidance, blessings, and support to endorse my candidature for the post of Foxy President, year 2026, election year 2024, consistently working for FOXY and trying to visit even smaller societies and to assist our common FOXian friends in any given situation. I have tried to serve FOXy. I assure to serve FOXy in the same way with the same zeal and enthusiasm. पथ का अंतिम लक्ष्य नहीं, सिंहासन चढ़ते जाना, लिए सभी को साथ, आगे है बढ़ते जाना.
So now these are our respected panelists, and we will be introducing them one by one as they come along. Before we start with the panel proper, sir, this is my basic question as an introduction. Why did you need an MTP Act? And the first act, when did it come, and for which indications?
So MTP Act was enacted in 1971, and before that, any termination of pregnancy was considered as a criminal offense. And for that, usually patient didn't go to a qualified doctor because doctors were not allowed to terminate pregnancy. So people used to go to either quacks or they were doing abortion practices by some homemade medicine, etc. And due to that, they ended into very severe morbidity and in few of the condition mortality also. So considering all this, one committee was formed, that is Santilal Shah committee, which was formed in 1966. And in that committee, 50% members were doctors and others were influenced by doctor. And one of our representative from FOXy was also there in that very committee. So committee had an opinion that termination of pregnancy should be made legal and registered medical practitioners should be protected if they have terminated pregnancy as per provision of MTP Act 1971. So with this act was enacted in 1971 and rules were made in 1975, and then after this act is in action. In 2003, there were some amendment, and again in 2020.
Sir, we will come to the amendments later. We will come to the amendments later.
Yes, I will just mentioning only. So in 2020, one more amendment came and rules were amended in 2021. So then after, it is known as a amended MTP rule 2021. And main goal was to protect registered medical practitioner who practices termination of pregnancy, to give all services for safe abortion to needy women, and to keep secret all the information related to that very patient who undergoes termination of pregnancy. So with these three aims, this act was enacted.
Thank you, sir. Thank you. Now we have Dr. Deepa Gupta, who's the Chairperson, Community Health and Public Awareness Subcommittee, AOGD, and member of Safe Motherhood Committee, FOXy, Director of Muskan Clinic. Over to you, Dr. Deepa.
Good evening, ma'am. Good evening, sir. Sir, we are so lucky to have you today here for this very, very important topic. Sir, actually, I am a private practitioner and running a standalone clinic. So, मेरा question जो आपसे है वो इसी के pertaining रहेगा कि sir, because like since we all have been dispensing and we have been prescribing medical abortion pills from our clinic. So I really want to know for my delegates, what are the prerequisites? Do I need to register my center for the MTP? or if I'm not registered, then is it legal? What are the prerequisites I need to do so that I'm legally safe, because I've been prescribing and dispensing medical abortion pills? That's the question from my side.
Dr. Deepa,
So
Dr. Deepa, these questions will be covered. These questions will be covered. Requesting you to please take the question as advised here, and that those questions are coming later.
Okay.
So, as far as this provision, important provisions of acts are concerned, there are two main provisions, and that is, one is place where termination of pregnancy can be done or allowed. So, place should be registered under MTP Act. And for that, one more area, in any government hospital or government aided hospital or any center, that is any clinic, any hospital recognized by government or district level committee, where you can terminate pregnancy. One more provision is person who can terminate pregnancy. Any registered medical practitioner who is allopathic graduate and registered with Medical Council of India with requisite experience can terminate pregnancy. As far as our gynecology branch is concerned, we are allowed to terminate pregnancy, and for us, no separate experience is required, because experience taken at the time of our curriculum of MD or DGO, it is considered in eye of law as far as this termination of pregnancy provisions are concerned. So these are two main provisions. And if we violate, say for example, we are qualified, but if we terminate pregnancy at unregistered place, then, or if place is registered, but person is unqualified, and if he has terminated pregnancy, in both the situation, there is a provision of imprisonment of 2 years, and which may extend up to 7 years, and fine of rupees 1,000 or even more is the provision as far as punishment part is concerned. So it is very much must to terminate pregnancy at registered place only. Hello. Hello.
Sir, the last part, that
Hello.
how effective the MTP Act was in preventing unsafe abortions. So what is your
Yes.
opinion regarding that?
Yes. So just I mentioned before this MTP Act, these patients are being treated or managed by quacks or unauthorized or unqualified person. So there were so many morbidity and mortality related to that. But after this act, usually a patient goes to qualified person or to recognized center, and this problem has minimized. But even today, few of the patient goes to quack or any unqualified person, and they may end up into some morbidity. And we many times we receive a patient with complication who are tried abortion either by their own biomedical pills or by some unqualified person. So with this MTP Act, main goal was to check this morbidity and mortality related to abortion services.
True.
Yes, next.
We can't hear
Hello.
you, Asha. Asha, you are not
Oh,
audible.
sorry. Yeah,
Yeah.
sorry. I had muted myself. Dr. Shalini ma'am is supposed to take this question. She is here, but for some reason she isn't responding.
No,
Yes,
yeah,
Shalini
ma'am,
ma'am.
I'm there.
Welcome.
I'm there.
Yes,
Welcome, ma'am.
welcome.
Yeah. Thank you, Patel sir, and yes. Thank you, sir. Thank you, Dr. Asha, for giving this.
Ma'am, we can't hear you. We can't hear you.
The question to you is that how many times and why latest amendment?
Patel sir, ma'am has asked a question. How
Yes.
many times was it amended?
Just I mentioned this act was enacted in 1971 and first amendment came in 2003. And in that very amendment, power were given to district level committee to give registration to eligible center. Previously, for registration of center, we had to apply to the health department of respective state. But now, district level committee can also give registration. This was the main amendment in 2003. And recent amendment came in 2020 and amended rules in 2021. So, with this amendment, there are so many new things were added as far as MTP services are concerned. So first, failure of contraception. Previously, it was available to married woman and to her spouse. But now word married woman is replaced by any woman and word her spouse is replaced by her partner. So irrespective of her marital status, she can avail services of MTP with indication of failure of contraception. So this was good amendment. One more amendment came. Previously, termination of pregnancy was allowed up to 12 weeks of pregnancy with opinion of one registered medical practitioner, from 12 to 20 with opinion of two registered medical practitioners, and after 20 weeks termination of pregnancy was not allowed. So with this amendment, now pregnancy up to 20 weeks can be terminated with opinion of one registered medical practitioner. From 20 to 24 weeks of pregnancy with opinion of two registered medical practitioners, pregnancy can be terminated in some special condition. There are some 7 conditions given in this amendment. After 24 weeks of pregnancy, previously it was not allowed, but now with this amendment, pregnancy can be terminated with opinion from medical board. And medical board can opine even after 24 weeks of pregnancy if there is a congenital fetal anomaly which are incompatible with life of fetus. So this amendment was in favor of patient. But very good part of this amendment is when this type of cases are referred to medical board is under obligation to opine within 3 days. And if opinion is in favor, then that very pregnancy should be terminated within 5 days. Previously, what happened when this provision was not there, people were seeking permission with writ petition before Honorable High Court. And Honorable High Court were referring the patient to medical board of respective medical college or state. And in those period, timeline was not decided. And in one of the cases, which was published in Hindu newspaper also, termination of pregnancy was demanded or asked in writ petition at 24 weeks of pregnancy, and High Court referred that patient to medical board, and when medical board opined, pregnancy was 36 weeks of pregnancy. So not to end up into this type of problem, in this amendment, medical board is given condition that they will have to opine within 3 days and pregnancy should be terminated within 5 days. So this is very good amendment as far as the termination of pregnancy beyond 24 weeks of pregnancy is concerned. One more amendment came in this rule 21 as far as privacy or confidentiality of patient is concerned. Of course, it was previously also there, but with this amendment, now punishment has made little stringent one. So if at all any breach of confidentiality of patient, if any information of patient undergoing MTP is revealed by person, then there is a imprisonment of 1 year and or fine or both. So these are some amendments which came in 2021 and which are beneficial to the patient and to registered medical practitioner who are doing practice of abortion under provision of MTP Act. One more area to take consent, it is very much mandatory to take consent of patient in Form C. Yes, next. Yes, Asha.
Yes, sir. So next we have Dr. Susheela Gupta, ma'am, who's the Director and Senior Consultant, GNH Excel Hospital, Shalimar Bagh. So over to you, Susheela, ma'am.
Yes, what are the violations of the Act commonly seen in the court, and are medical abortions are covered under the Act?
Yes, as far as violation of this Act is concerned, termination of pregnancy done at unregistered place, done by unqualified person, done in unsafe method or unsafe atmosphere, and consent is not taken in Form C. These are the usual allegations or usual condition in MTP related cases. And as far as this unauthorized person at unapproved place, I mentioned prior also, there is a provision of imprisonment from 2 to 7 years and with fine or both. So one cannot afford that. And we should be very clear that we should terminate pregnancy at registered place also only and by qualified person only. As far as second question is concerned, medical abortions also covered in MTP Act. So even if you go with medical termination of pregnancy by medical method, all the formality related to provision of MTP Act will apply. So take consent in Form C to have opinion from a medical person if pregnancy is less than 20 weeks by one medical registered medical practitioner. So all the requisites related to MTP Act will apply even if you terminate pregnancy by medical method.
Yes, sir. Thank you very much. But at the same time, there is very much confusion because this tablet is being sold on over the counter. Chemists are selling, patients are taking herself. Or when we have to do so much of written work and we have to inform the MTP center, yes, my center is approved as a medical abortion center and we are doing so much of the written work, definitely we are charging money from the patient little more than what is our consultation. Because uske baad mein we just advise them to be connected with us in case of any heavy bleeding or any pain. We are giving like those consultation also 3-4 consultation. So we are charging little more. तो patient कहते हैं तो chemist के पास मिल रही है, हमने पहले खाई थी पूरा निकल गया. दूसरा जो मेरा बहुत बड़ा एक सवाल है सर, ये वाला जब मेडिकल मुझे ऐसे लगता है कि जो MTP एक्ट बना है ये इससे कोई सेफ अबॉर्शंस कितने ज्यादा हुए हैं. किसी जमाने में हमें लगता था ये पॉपुलेशन कंट्रोल का भी एक मेथड है और मुझे लगता है कि इसीलिए इंडिया में कॉन्ट्रासेप्शन बिल्कुल भी यूज नहीं हो रहा है. Patients are using this MTP method only for contraception basis. They do not use at all contraception because it is done in India only so freely. और जितना freely हम जितना accessible MTP करते जा रहे हैं patients को, तो डॉक्टर्स के ऊपर तो बहुत सारे शिकंजे आते जा रहे हैं और पेशेंट्स ऐसे सोचता है कि एमटीपी में तो कोई रिस्क है ही नहीं. They are not listen. They are not listen to take any contraceptive. Or every time अगर like if I am scolding so much, then they are going somewhere else. कि आपने एक MTP कराया फिर उसके बाद contraception लो. अब 2-2, 3-3 बार you won't imagine 8-8, 10-10 बार पेशेंट आते हैं MTP के लिए.
So in this situation, yes, I got your point. So in this situation, when patient is brought to us with complication and when there is a history that she has taken MTP pill over the counter or by some unauthorized person or so of course we have to treat that very complication because we are duty bound to do that. But in this situation, if patient is ready to file complaint, you can inform police also in this situation. But many a times, in most of the cases, it is observation that it is very difficult to prove by patient that she had taken this pill over the counter, because in this situation, pharmacy people are smart enough. They will never issue a bill of medicine purchase. So in this type of situation, even if in court matter, they will be given benefit of doubts and they are free. If we go on association level, Foxy level, IMA level, in past, this was done, and for time being, it was banned, and it was given instruction by Food and Drug Department to pharmaceutical that they can sell this medicine only to the hospital or to the clinic who are registered under MTP Act. But there was big agitation on part of pharmacy level, all this chemist shop, etc. And ultimately, this was withdrawn. So this has happened. But if in case of complication, if some cases are made against pharmacy people, and if it is proved, then if it is proved, then they will be in big trouble, because they are not qualified person. Medicine from where they have sell or sold are not qualified, I mean registered place. So they will be in big trouble and they will be behind the bar. But to prove that this pharmacy had sold this medicine is little difficult one.
MC sir, moreover, we are not giving MTP number to such patients who are coming with incomplete abortion, because we have not started the process. We are just, admitting them as incomplete abortion. Because how can we ascertain that she has taken MTP pill, as very rightly said by you? So we are not giving any MTP number. They are, admitted for management of incomplete abortion. So are we correct, sir?
So when patient comes with this type of complication, whether PV or pain in abdomen, whether incomplete, inevitable, whichever, so it doesn't come in purview of MTP Act.
Yes,
and
yes.
so
Sir.
we have not to go for any
MTP
form
number.
formality, no form,
Yes.
nothing. We have to treat that very patient as we treat any other patient. They are come with any complication. Say, for example, complication of pregnancy in other condition. As we treat, we have to treat with informed consent, and if
Absolutely,
at all
sir.
it is required admission, then we can treat accordingly.
Yes, sir. We are doing that, sir. Thank you.
Yes, yes, thank you. Yes, next.
Next, we have Dr. Kiran Agarwal, sir. Look at her garden.
Very good.
So she's an avid gardener, a very public person. Welcome, Kiran, ma'am.
Thank you, thank you, thank you all. And Dr. Patel.
Yes.
Yeah, so far, whatever you are answering, that is so useful, really, and to the point. I just want to ask, what are the forms to be filled exactly and carefully? Because the documentation has to be very perfect. We all know that. And what about the personal privacy of the lady under the Act? Because now under the POXO Act, when the question of MTP comes, there is now the courts are understanding is developing that you don't reporting is also mandatory, and then the understanding is developing that you keep the privacy of the person, of the girl.
So as far as different forms are concerned, let us start with A. So form A is prescribed form for.
Can't hear you.
Registration of place. With all the details and requisite fee, etc. If we are B, the result is
I think your
certificate of
voice,
registration.
your
Form
voice is
C.
getting interrupted. Your voice is getting.
Sir, video बंद कर दीजिए. तो थोड़ा बैंडविड्थ मिलेगा. वीडियो बंद कर दीजिए.
Can't hear.
No, he will.
Okay, sir, can you hear?
Hello.
Sir is traveling now. Maybe he's not audible now.
Okay, he's traveling.
So, what are the forms that you actually fill? We are filling forms, no? Or our staff is
Am I
doing it for
audible?
us.
Yes,
Yes,
now,
Now
sir.
yes. Yes, now yes. We can't see you. Not audible. Not audible.
अनीता जी बताइए कौन से फॉर्म भरते हैं?
हाँ जी. So whenever patient comes to us, we have to, fill two forms. One is of opinion and the other is of the consent. So these are very, very essential. And as sir has already told, up to 20 weeks now, single registered medical practitioner's opinion is enough. So you can give the opinion that for certain reason, out of 5 or 6, you have to take the correct reason. For what reason you are, most likely it is, usually contraceptive failure. So you have to, slash others. The only correct option is to be left as far as making opinion is concerned. The other is the consent form. And what is important, that a woman can sign for consent for MTP. Her husband's consent is not required or partner's consent is not required. But to be on the safe side, if you wish not to enter in any kind of controversy, it is, prudent and logical to get it countersigned by husband as witness, or maybe another independent neutral witness can sign your forms. Now, it will depend. For 20 to 24 weeks, you have separate forms. And for requesting to the medical board, you have to fill other forms. And the report will be sent back to the client within 3 days of the opinion being given by the medical board. It is also there in another form. So these forms, all of us must know. We should have a soft copy. And please do not use the older ones. Use the new form. New forms are available on the website of Government of India, MTP Act. Please use the newer ones, because, our state nodals, they strongly object that you should not use the previous ones, because in previous forms, it was written up to 12 weeks. Now you have to use it up to 20 weeks. So make sure that you have the soft copy of the all new forms.
Yes, Can I say
Yes,
something?
ma'am. Yes, ma'am.
There are two forms, Form 1 and Form C. Form 1 should be filled like what Dr. Anita has described already. The main character nowadays, few centers are saying it should be filled with all the letters should be capital letters. All the filling and saying capital letters. Plus Form C, there is one other form, Form C. It should be filled by whenever patient is not adult.
Ma'am, you have got muted.
Form C should be filled when patient itself is not adult or not eligible for consent, or whenever fellow is not mentally stable.
Yeah, that is the other part of it.
Form C. Form C. Form 1 and Form C.
And another thing is, be sure of the identity of the client. Yesterday,
Aadhaar card.
day before only, SR admitted, and later on the husband comes and says कि मैम इसका नाम तो कुछ और है, आपने तो ये फाइल बन गई है. तो ये सब प्रॉब्लम हो जाती है, क्योंकि after you make the MTP case sheet, you are not going to mention the name of the client anywhere. Suppose you are sending blood group or blood group you are doing or other investigation, you have to just at the time of admission give her MTP number, and after you give MTP number, enter in the MTP register. You will not use her name.
Yes.
The client's name has to be kept secret because of the privacy clause, and you have to just mention the MTP number. That is a very important thing which everyone should keep in mind, and be sure about the identity of the patient, because we have had with certain bad experiences, because they will just get their girlfriends in name of their wife and get MTP done. So be very, very cautious about identity of patient. So we can go on to next question, Asha.
That's you, and everybody knows you. But I would request everyone to vote for Dr. Anita Rajorhia, ma'am. A diligent, very happy, very cool gynecologist, as I see her. And you all must be knowing her much more than that. So,
thank you, Asha. You are a dear friend. So, is MC sir available, or we discuss it amongst ourselves now? Sir
we
is
have
traveling.
to discuss amongst ourselves.
Okay.
Because sir is.
Yeah, I'll put the question to all the learned panelists now. Who can be shown the document to the lady? Now, this lady has got MTP done. Now, her husband or boyfriend comes that show me the records. Can you show the records to anyone? Any family member? Any police person? So, what is the opinion of our learned panelist?
No,
You
not at
cannot
all.
show the documents to anyone.
Yeah, not even partner. If the patient has given consent secretly, you don't give the details even to her husband or
See,
partner.
the thing is, even if she has not given it secretly, you are still not supposed to show the documents to anyone. That is a very basic thing. It has only if there is a court order, then you can show.
Yeah. So sometimes, people have this question or query in their mind, what to write in discharge slip. Should we write MTP number, or should we write the name of the client? We can write the name of the client, but because it is a secret document which is issued in her name, you may write the name, but you tell her that this is your confidential document. If she shows, then we are not breaching any confidentiality. So this is one point which is important. And otherwise,
and another thing is that sometimes the patients want reimbursement. They want medical reimbursement.
डॉक्टर अनीता, डिस्चार्ज स्लिप वो जो हम एमटीपी नंबर देते हैं उसका ABC या XYZ व्हाटएवर इट इज, डिस्चार्ज स्लिप भी उसी नाम से वी आर मेकिंग डिस्चार्ज स्लिप ऑन दैट नेम ओनली.
That is also all right, but if the patient wants, like for reimbursement, she is asking that issue in my name, then
ma'am, you will have to give the discharge slip by name, because antibiotics and all cannot be issued unless they keep a copy of the name and the prescribing doctor. Maybe you don't write MTP on it. That is a different issue. But you have to write on the discharge slip. But the basic thing is you are giving it to the patient. You are not giving it to anyone else.
Yes. Now you can tell her this is a confidential document. If you are sharing it with somebody else, then it is your responsibility.
I am back again.
Absolutely.
Yes, sir. Yes, sir.
Yes, there was some network issue. So we were discussing about forms, and I had discussed Form A, Form B. Now one more form is Form C, and this is form of consent. So we have to take consent of a patient in prescribed Form C only. Of course, we have to take consent as an informed consent in other form, but consent taken in informed consent cannot replace consent to be taken in Form C. So consent in Form C is very much required. One more form is Form D. This is the form which is the opinion of medical board. So medical board will have to opine in prescribed form, that is Form D. One more form is Form E. Form E, when pregnancy is more than 20 weeks, less than 24 weeks, and opinion of 2 registered medical officers are to be put on record. So this is to be put in Form E. So this is prescribed form. Some other forms are Form 1. Form 1 is again opinion up to 20 weeks of pregnancy with one registered medical practitioner. Form
We have
2,
not, yeah.
Form 2 is monthly reporting. We have to report of MTP done in last month as a monthly report in prescribed Form 2. One more form is Form 3. Form 3 is admission register, or we can call it MTP register. It is Form 3. And in Form 3, there are different columns. So we have to fulfill all the information of patient in that very Form 3. That is name of patient, address, age, marital status, weeks of pregnancy, who opined to terminate pregnancy, by whom pregnancy was terminated, by which method pregnancy was terminated, and which method of contraception was adopted by patient after termination of pregnancy. So these are some prescribed form under MTP Act, this 1971 and amended rule 2021.
16
Yes,
columns are there, 16 columns. Make sure your MTP register has those 16 columns. It
Yes.
even has date of discharge and name
Yes.
of the service provider. Everything
Yes,
has to
yes.
be filled.
All the details are therein.
Sir, we are sending monthly report. So, are we breaching the, privacy of the patient by sending MTP form?
No,
Although
no, no.
it is prescribed by
monthly
law of land.
Anita,
Yes.
in
Yes.
monthly report, it is prescribed form, that is Form 2. And in that very form, we have to go with statistic only. Say, for example, in month of June, how many termination of pregnancy happened in your hospital? Say, for
Yes.
example, 20. One more column, up to 12 weeks. How much? Say, for example, 4. From 12 to 20, or 20 to 24, more than 24 weeks. Then there is a column for indication. By failure of contraception, how much MTP done? 3, 4 or so. So this way, we have to go with figures only. No
Yes.
personal identity of any patient is to be revealed in Form 2. So there is no breach of confidentiality of any patient when we forward monthly report to appropriate authority.
Thank you, sir. Thank you so much.
Yes.
Sir, discharge slip to be given to by the name patient. If the patient is
No. Once all the details of that very patient who is undergoing MTP is entered in Form C, that
Yes.
is admission register, number is given to that very patient. Say, for example, 16 by 2024. Then after, all the correspondence with we will be with number only, not name. Say, for example, OT register. If you have terminated pregnancy by surgical method, then in OT register, we have to enter number of patient and not any detail of patient is to be entered, because number which is given to the patient and which is entered in OT register, if at all any information is required, we can take that information from MTP register. But in OT register, no personal identity is to be revealed. In any other register, autoclave register or indoor register, at everywhere number is to be given and not name or personal identity of patient.
Sir,
If the patient
sir, I am
requests
asking discharge slip.
One after
Discharge,
what?
discharge slip, discharge summary.
In
When we are
discharge summary
giving-
also, we have to go with number.
Yes. I wanted to confirm that only because we
if
are
the
giving
patient
number.
wants in her name for reimbursement purposes or for
So,
official,
yes.
then what is to be done?
If at all it is for reimburse or any other purpose, say for example, if patient is working woman and if she wants certificate to grant leave, then we will request patient to give application in writing that I need this information with my name. Say for example, certificate advising race or any prescription or any other papers, then patient will request us, and whatever information we give with name, we give to the patient. Till then we are not breaching any confidentiality. Patient is free to give that information to anybody. That is up to her. But we have not breached confidentiality of patient. So we are not in any issue in this type of situation.
Okay. Thank you, sir.
Yes.
Next, we have Dr. Kiran Chhabra, ma'am. She is the VP of Delhi Gynec Forum Northwest. Ma'am, over to you.
Good evening, everybody. Thank you, Dr. M.C.Patel, sir, and Dr. Asha for having me here. And I will say all the best to all the contestants for the election of POXI this year.
Thank you.
To M.C.Patel, sir,
Thank you, ma'am.
That because we know that MTP pills are available over the counter, how this reporting is being done on the MTP stand, and what is the role of gynec when such a lady comes with retained products?
So if it is with retained product, it is a complication. And complication of any pregnancy, we have to deal with accordingly. And for that, no formality of MTP forms, etc. As far as OTC product, we have discussed in past previous also. So if patient comes with any complication, we have to naturally mention in a history that history of taking product on OTC, and we have to manage that very patient. And if patient is interested to file complaint, we have to inform police also.
So, sir, there are two questions from my side on this OTC availability of the pills. One of my patients says that his mother sells more than what other medicines he sells in a day. He sells so bulk of the MTP kits. So there is no recording on the government record that how many MTP kits are sold per day. I'm talking of one chemist. So there are thousands and lakhs of chemists in India who are selling this medicine over the counter. And the patients are taking and the government has no record of it. Why there is so much of pressure on the doctors to keep record of every small thing, even OTC, even these MTP pills? This is my first question to you.
But I mentioned prior also, this can only be taken on level of association. FOXI, IMA should take this task. In past, it was try was done, but ultimately, in a protest of pharmacy, the government didn't take any serious action.
That is true, sir. So when our FOXI will take action on this?
When Dr. M.C.Patel becomes president of FOXI.
Okay, sir.
And for that, you have to vote me, support me, and you have to elect me as a president. There are so many issues other than this OTC product. Madam, there are so many issues related to MTP Act, related to PCPNDT Act, related to ART Act, Surrogacy Act. So I always appeal and say that you have seen hardcore obstetrician as a president of FOXI. You have seen hardcore IVF specialist as a president of FOXI. You have seen IVF specialist or this endoscopic surgeon as a president of FOXI. Now you see medical legal person as a president of FOXI, and you see the change.
Okay, sir. So can I ask one more question which is not relevant?
Yes.
Kiran ma'am,
Yes.
we would have that session later.
Okay.
Yes, sir.
Yes, I was telling that only if time and Dr. Asha Jain permits.
Okay.
No, sir, actually we have 15 minutes and 6 questions left.
We will complete round of all
So,
the panelists.
Deepa ma'am, over
questions.
to you, please. Dr. Deepa Gupta ma'am. Over to you, please.
Probably
anybody else can take it.
Achha, this is a different question. Okay. So, can I take it?
Yes, ma'am.
Yes.
Please go ahead.
So, what has to be done, sir, if lethal deformities are detected in anomaly scan on MTP? Non-lethal anomalies detected at 27 weeks on MTP? Can MTP be done?
One by one. Ma'am, one by one.
One by one. As far as lethal deformity is concerned, up to 20 weeks with opinion of one registered medical practitioner, we can terminate pregnancy. There is a valid ground. If pregnancy is more than 20, less than 24 weeks, in lethal anomaly, we can terminate pregnancy with opinion of 2 registered medical practitioners. If pregnancy is more than 24 weeks, then with opinion from medical board, we can terminate pregnancy in lethal anomaly. So it is allowed.
So, sir, okay, sir. And if there is a non-lethal anomalies which are detected at 27 weeks of, can MTP be done in such cases? And
no,
under which...
in this situation, even medical board is conferred with power to opine only in case of congenital fetal anomaly which are incompatible with life of fetus. When there is a non-lethal anomaly and if pregnancy has advanced to 27 weeks, in this case, one will have to rush to Honorable High Court seeking writ petition for seeking permission or termination of pregnancy.
So you have answered this question. What is the legal procedure involved? So we have to go to the court to seek help.
Yes. So writ petition before Honorable High Court seeking permission of termination of pregnancy.
So my next question to you is, sir, who can give consent if the lady is major? She herself or she requires her partner?
No.
Is
When patient is major, when patient is major and mentally sound, only and only she can give consent on her behalf. Nobody else can give consent on her behalf. If she is minor or mentally challenged, then consent of guardian is required.
Okay. So is it separate? Do we need a separate informed consent along with Form C, sir?
Yes. Because in Form C, of course, it is prescribed form. It is very mandatory to take consent in Form C. But it is a very simple form. And it is written like this. I give my permission. In this, it is not informed consent. So we will have to go with 2 consent in this situation. One informed consent as we take in other condition also, and one mandatory consent in Form C. But for this, I would like to refer a FOXY uniform consent, which are available on FOXY website. We 3 medical legal experts prepared different 30 consent, and in those 30 consent for termination of pregnancy by medical method and by surgical methods are also available, and you can download those consent and use in your day-to-day practice.
Okay, sir. So, sir, can you share any interesting case with us, which will be a learning for us so that we can avoid litigations in those?
Yes. In one of the cases which happened in city of Ahmedabad only, in 2003, pregnancy was terminated, center was registered, doctor was qualified, and there was no issue, pregnancy was terminated. In 2004, just after 1 year, there was quarrel in the family and patient filed a complaint against in-laws, and it was allegation that termination of my pregnancy was against my will without my consent. So doctor was called in court of law, and court asked all the record, that is consent taken in Form C, opinion, that is Form 1. But for any reason, doctor couldn't produce all those records. So court ordered to arrest doctor from the court only, and doctor was put behind the bar. After 3 days, party had a compromise, case was withdrawn, and then only doctor was out of bar. So if you have not taken consent in Form C, you are triable under section 313 of Indian Penal Code, and there is a provision of imprisonment for 10 years for that. And that is why consent in Form C is very much must.
Okay. Okay, thank you so much, sir. Thank you for very.
Okay, welcome.
Yes, ma'am, I'm there.
Yes, next.
Yeah. Yes, sir.
Over to Shalini, ma'am. Sorry, I was muted.
Yes,
Please
yes,
go ahead,
sir.
ma'am.
Yes. So, sir, my next question to you is that if there is an MTP of more than 24 weeks, and if the baby delivers live, then to whom custody should be given?
So in this situation, at the time of taking consent, we will have to counsel patient that after 24 weeks of pregnancy, it is likely that baby may come alive, and you will have to take. Then naturally we have to give custody to the patient. But many times it is our observation that patient and patient party refuses to take custody of baby.
Yeah.
Yes, next.
Yes, sir. So if the patient and the relatives are not willing to take custody, then what?
So you can see patient in NICU, in government hospital, there is no problem. But in private hospital, one more question will be there, that who will bear the cost of NICU? And in this type of situation, one more situation, is there any role of police, or can we consider feticide before termination of pregnancy? In foreign country where termination of pregnancy is official or legal, in those country, it is very much necessary to go for feticide first and then termination of pregnancy when pregnancy is more than age of viability. But in India, still there is a gray area as far as this part is concerned, whether prior feticide can be considered or not. But if patient has given consent to take custody of fetus, if fetus comes alive, then we can inform police if patient is not willing to take custody of that living fetus. So these are some areas, and that is why I asked prior also, here comes role of FOXI, here comes role of IMA to approach government to clarify this type of situation. In this type of situation, how one should practice. And here comes, just I told previously also, and in a lighter way I tell, you have to vote Dr. M.C.Patel, you have to elect Dr. M.C.Patel as a president of FOXI. He is going to take all this issue at government level. Thank you.
Yes, sir. Thank you so much, sir.
Thank you.
Now we have Susheela ma'am, sir. Dr.
Yes,
Susheela ma'am.
welcome, madam.
Yes, yes. A 26-year-old, Gravida 3, Para 2, Live 2, having 22-week pregnancy for MTP with the reason given failure of contraception. Can MTP be done or not? Since
No,
it is
we
more than
cannot,
20 weeks.
because failure of contraception indication is available up to 20 weeks of pregnancy. And here pregnancy is 22 weeks. We cannot terminate pregnancy on that ground.
Yes. Yes, thank you very much.
So this sir is Kiran Agarwal ma'am, who had been helping Nirbhaya's mother. So
Yes.
this is after the judgment. Yes, Dr. Kiran.
Yeah.
Over to you.
Yeah. So my question to Dr. Patel is next. A 19-year unmarried girl was brought to the hospital in shock by an A&M practicing in periphery who did her criminal abortion at her clinic at 3 months of pregnancy, accompanied by her parents. On examination, patient was in shock. Omentum was hanging through vagina. What to be done? First resuscitation and management, or should do the FIR and wait for the police?
Naturally, we have to treat patient in emergency is a first requisite. In famous case of Parmanand Katara, court has also mentioned that you first treat the patient, all the legal formality afterwards. So you have to resuscitate this patient. If patient is in shock, naturally we have to go for, and laparotomy is to be considered, and we have to treat patient accordingly. And then after, if patient is willing to file complaint against that very A&M, we have to inform police. If patient is not willing, then we cannot.
Thank you. Thank you, sir.
Yes.
Again, over to you, Dr. Anita.
Okay. Thankfully, this girl is also 22-year-old. The questions have been framed very smartly. Thank you that the girl, previous girl was also not less than 18 years, 18 years, otherwise FOXO would have
Yes.
come into vogue. Now this girl again is 22-year-old. She is also unmarried. She came to the doctor with her boyfriend. Now she is requesting you to terminate the pregnancy, which is around 3.5 months. So what is to be done, sir?
So in this situation, if your center is registered, you are qualified person and patient is 22 years, that is major. If she is mentally sound, she can give consent for termination of pregnancy. You can terminate pregnancy.
So suppose if she is uneducated and she says that boyfriend can give the consent. So is the consent of boyfriend valid? Because suppose there is nobody else in that particular city.
When patient is major, when patient is mentally sound, only and only patient can give consent. Even if she is illiterate, then she can go with thumb impression.
Thumb impression. Okay. So in what situation we may allow the unmarried girl to allow her partner to sign for her? Is it hypothetical
No. If she is major, mentally sound, nobody is allowed. Only consent of patient. If she is minor, then case is different. Then we have to go with termination of pregnancy with consent of guardian. In this situation, we can allow any guardian. But in this situation, guardian should also be major. Because if her boyfriend is minor, then he cannot give consent in this situation. But in this situation, it becomes a case of POXO. So we have to inform police. We can terminate pregnancy. We have to preserve product of conception in normal saline. And we have to hand it over to the police for further investigation.
She is 17
Thank
years
you,
old.
sir. We have 5 minutes.
Okay.
Dr. Anita will do POXO. We'll do POXO later. Today we stick to MTP.
Sir,
Kiran Chhabra, ma'am.
Can I ask one question? Only one small question.
This is the last one. After this, you can ask. This is the last case situation.
So once again, good evening, sir. There is a question to you. If a 20-year-old female comes to you who has conceived through ART, but they are pets, and the fetal reduction is obviously advised for that. So what do you say? Should the center be registered for MTP? Does it come under the preview of MTP Act? And which forms are to be filled?
So this doesn't come in purview of MTP Act because here you are reducing from triplet to twins or twin to singleton. But here there is no termination of pregnancy because pregnancy is still continued. So here no, it doesn't come in purview of MTP Act. So no formality of any form related to that. And in this, even you can deal with at unregistered place also.
Fortis Hospital.
So if, sir, and another question to you is, if a patient center is registered and patient person is qualified, 6 weeks pregnancy, she wants MTP. So we can give medicines, or we should have to go for the procedure, surgical procedure.
We can offer both the option, medical and surgical method, and we can offer with all the details. If patient is comfortable to go for medical, then we can advise medical method. If patient is willing to go for surgical method, we can go for surgical method.
Okay, sir. So one question I have to you is that if a patient comes to me at 12 to 13 weeks of pregnancy, she is a gravida with first female child of 3 years, but still wants MTP. So what precautions as a gynecologist I should take so that I do not come under the PCP Act because 12 to
these are the vulnerable group of patients when there is one female or 2 female children previously and patient comes to you for termination of pregnancy at that gestational age of 12 to 13 weeks. Because if at all you ask, why you waited for this? She will tell that I couldn't make out that I am pregnant. There are so many vague argument on part of patient, but we should be very vigilant in this situation. And I would advise better to avoid to terminate this pregnancy. Of course, there could be some genuine patients also, but we never know. that who is genuine and who has come with sex determination done somewhere else. And if at all she is terminated at our place and female fetus is delivered and some appropriate authority comes, and then we may end up into some big problem. So better not to deal with this type of situation or patient.
Sometimes patients come also with 17, 18 weeks with this, that they want to get the abortion done. Maybe they have failed child before. Then what to do? Then also we can do now.
The same. If in this type of situation, many a time patient is willing to go for tubal ligation also with termination of pregnancy. So in this situation, there is no problem because patient is very clear not to have pregnancy further, and she has opted option to go for tubal ligation also. But if it is a mere termination of pregnancy, and if there is a history of one or more than one female children, then we should be cautious.
Okay.
Thank you so much. सर वो तो हो सकता है कि कोई फैमिली चाहता ही ना हो फीमेल हो, फर्स्ट मेल है, सेकंड आल्सो मेल चाहता है।
और पंजाब में तो ऐसा बहुत हुआ ना सर, पंजाब में तो ऐसा हुआ कि जिनकी लड़के थे उन्होंने भी अबॉर्ट कराई लड़कियां।
होता है, इसीलिए मैंने बोला ना better to avoid abortion in this type of vulnerable gestational age group.
सर जो सेंटर जो एमटीपी सेंटर रिकॉग्नाइज होते हैं, वो जो सेंटर सर्टिफिकेट होता है, दिस इज लाइफ लॉन्ग सर्टिफिकेट एंड आवर सेंटर जैसे लाइक इट वाज रजिस्टर्ड अराउंड 30-35 years back and that certificate is saying you can do MTP up to 12 weeks. Although we are not doing more than 12 weeks, now the law has come.
In that very certificate, was it mentioned that permission is given to terminate pregnancy up to 12 weeks?
Yes, लिखा होता है उसमें, लिखा होता था पहले।
Yes. I am also having a MTP registration, and long back I had got it. But in my certificate, it is not mentioned that I am allowed to terminate pregnancy up to 12 weeks. So if it is not writing like this, then with this amendment, your center is automatically registered to terminate pregnancy beyond 24 weeks of pregnancy also. No fresh registration, no fresh application, no inspection, nothing. But if in your case, if it is written that your center is registered to terminate pregnancy up to 12 weeks, then you will have to inform appropriate authority or apply appropriate authority to extend it from 12 weeks to more than 24 weeks if you are interested to terminate pregnancy more than 12 weeks.
Okay. Thank you, sir. Thank you, sir. Because it
Can I ask something? If you want to terminate more than 20 weeks, that committee will come, district level person will come and they will check whether you have laparoscopy set, where you have OT, you have association with higher center where you can arrange blood from. Only then they will allow you to give more than 20 weeks.
It depends upon appropriate authority of respective area. But so many appropriate authority go with this amendment, and in amendment it is mentioned that if your center is already registered for termination of pregnancy, now your center is automatically registered to terminate pregnancy at any given gestational age as per provision of MTP Act. So many appropriate authority go with this word and they allow. And few of the appropriate authority insist that there should be separate inspection and there should be separate certificate again to allow termination of pregnancy more than 24 weeks. Depends upon appropriate authority. But if you go by law, true spirit of law in this act rather, it is mentioned that no need to go for re-registration.
Excuse me, sir.
Yes.
Can I ask something? The Supreme Court lawyer who wrote this POXO Act, I had some discussions with him, and he was asking me why in the this new MTP Act, why the it was this 20 weeks from 24 weeks was increased. What was the reason for this? Are we aware of that?
No. At the time of this amendment, there was discussion in Lok Sabha and Rajya Sabha that there are some fetal congenital anomaly which are detected after 20 weeks of pregnancy.
Okay.
And many times they are lethal one. So
Okay.
in this situation, if termination of pregnancy is not allowed, then naturally they will have to rush to Honorable High Court seeking writ petition for termination of pregnancy, and important time is lapsed. And in this situation, condition of patient may worsen and morbidity or mortality may happen. So considering this, in Lok Sabha and Rajya Sabha, it was discussed, and then it was decided to extend the limit to terminate pregnancy more than 20 weeks with all these requisites which are in amended rule.
Okay, thank you.
Sir,
One more
has
question, sir.
yeah.
Some of our
Okay.
pediatricians, they want to know, when does the life begin biologically and legally? And do the unborn fetuses have rights?
So as far as age of viability is concerned,
Yeah.
previously it was considered 28 weeks, but now with modern gadgets, even 24 weeks of baby are also saved and survived. But it is not thumb rule. So we will have to go with a guideline from appropriate authority that up to what gestational age we should consider it. And according to them, because in each area, interpretation on part of appropriate authority is different. So where you practice, you should have guideline from that appropriate authority. It is better.
But what are there any present guidelines on viability, clear cut?
No, I have no idea, madam, as such.
No. Do the
Sir,
unborn fetuses have rights?
Yes.
Suppose
Pardon?
this, do the unborn fetuses have rights?
No, no.
No.
Sir, has the MTP Act now defined what are the lethal anomalies and what are the non-lethal? Because it was subject of
Anita, in law, there is very common dictum. Law doesn't teach you medicine. We have to practice medicine as per our standard medical norms. In our standard textbook, in list of lethal anomaly, which are anomaly are listed? They are lethal anomaly, and which are listed in lethal, I mean non-lethal, they are non-lethal anomaly. Law will not define that which are lethal and which are non-lethal. That is in our medical textbook.
Okay. Okay, sir. Because there was no list as such given, no?
No. But that is our at our discretion in medical science, which are lethal anomaly, which are non-lethal. Say, for example, hair lip, cleft palate, polydactyly. These are considered, of course, legal. I mean, congenital anomaly, but they are not lethal.
So the client can apply to medical board saying मेरे को नहीं चाहिए, मेरे को perfect बच्चा चाहिए, पर medical board decline कर देगा ऐसे में, है ना sir?
Yes. So they
Then she
can apply to medical board.
court, sir. Can she challenge the decision of medical board in court? No, she said, I'll go to court.
Yes, opinion of medical board can be challenged by patient. We have not to challenge because we come in picture when patient comes with report from medical board, permission from medical board in case of pregnancy more than 24 weeks. If there is no report from medical board with patient, we have to straightway deny. We cannot terminate pregnancy.
So it is the duty of the patient party or the client to get permission from medical board.
Naturally, patient, not doctor.
Yes.
We can guide them. We can guide them where they have to apply and how they have to apply. But that is whole procedure will be done by patient only.
Okay.
Excuse me, sir. We are like 8:45 now. It's 8:45 now.
So we have to conclude.
Yes, sir.
Asha ji, one question last. Sir, are these on-counter medicines safe for abortions?
Pardon?
Are these on-counter medicines safe for abortion?
Only under medical supervision, madam.
Who has prescribed? Who has prescribed Qualified
Yes.
doctor has prescribed, or patient has gone straight away by herself and taking medicine.
Should they be stopped?
Yes.
Should they be
discussed
stopped as policy?
Same we discussed prior also. We discussed all this.
Sir,
Ma'am, we are
MTP
getting-
should be stopped as contraception. MTP should be stopped as contraception.
Yes. We should promote more of
MTP should be
contraception.
stopped as contraception.
Stopped as
We should not
contraception.
take patients on failure of contraception because 99% of the patients do not take any contraceptive devices and they straightforward come to the doctor with MTP. They want MTP and then they go to the courts against the doctors. Doctors don't go to their policymakers, don't understand this thing. Why they can't put that responsibility on the patients who go to the to doctor for the MTP?
Yes.
So one of the faculty has also mentioned that many of the patients consider termination of pregnancy as a method of contraception, and we should not encourage it.
Stop.
Yes, we should not encourage this type of patient.
सर गवर्नमेंट को 2 बिल लाने पड़ेंगे, एक पॉपुलेशन बिल और एक एमटीपी बिल. MTP should not be used as a contraception and फिर population bill.
Yes.
अरे मैम इतना कॉन्ट्रासेप्टिव बास्केट एक्सपैंड हो गया है, सब कुछ अवेलेबल है, तो क्यों नहीं हम
डॉक्टर अनीता
काउंसिल
लेते
करते?
कितने लोग हैं? आप बताओ लेते कितने लोग हैं?
नहीं,
आप लोग
प्रॉपर्टी सिर्फ पेशेंट को एक कॉन्ट्रासेप्शन पता, दैट इज इमरजेंसी कॉन्ट्रासेप्टिव पिल, दैट्स इट. पेशेंट और कोई कॉन्ट्रासेप्टिव यूज ही नहीं करता है.
लगवाई, आपने कॉपर्टी लगाई डिलीवरी के बाद, सिजेरियन के बाद, पेशेंट जाता है प्राइवेट में जाके निकलवा लेता है.
पता है, it is our request not to get them removed.
नहीं, it is your
That is
request.
only
We
way.
also tell them not to take it out. But
Yes.
still, if I refuse, they will go to somebody else, then they will go to somebody else. They keep on running
At
from
least
one
we
place to
can
another.
control
How many
ourselves.
you
Na?
can
We
stop?
will not do that. Until unless there is a medical indication of removal, we should not, because
Madam, that
lot of
will be
counseling goes in PPI-UCD
only
also.
because we have thousands of doctors. That will only be possible when the FOXY, our association, says or request all the doctors not to do that.
Yes, yes. Our state nodal is requesting each and every, part of Delhi, state at least, that please do not, remove PPI-UCD, which has been put with so much of effort by government doctors. A lot of time goes for counseling by our peripheral workers and doctors. So please request. Yeah.
Sure,
Thank
sure.
you. Thank you, ma'am.
Thank you so much. It was a very nice panel, sir.
Thank you.
And we would like you to do in our associations later on. Once you
Thank
become
you,
the
madam.
president.
Always welcome.
सर भूल मत जाइएगा, दिल्ली में आपको आना है टॉक देने.
Always a pleasure
बिल्कुल.
to listen to you.
Kiran Chhabra madam.
जी sir.
In 26 there will be AICOG at Delhi, and if
Okay.
at all
Yes,
I
I
am
know
elected, and if I am elected, I am going to be installed as a president FOXY at Delhi only.
Okay, sir.
Okay.
And that is
It will be an
up to
honor
you.
for Delhi.
Yes, in your hand
दिल्ली के
only.
लिए.
So
दिल्ली के लिए वैसे बहुत बड़ी
Sir,
ऑनर की बात होगी सर, आपका इंस्टॉलेशन होगा तो.
it is in your hand only to
हाँ,
make it possible.
बिल्कुल बिल्कुल.
And
बिल्कुल सर,
my try will be at the time of installation, chief guest will be Narendra Modi.
Okay.
अरे वाह.
Okay.
Good. Very nice. We would also like to see him in person.
Yes, thank you.
All the
lots of
best.
best
All the
wishes
best.
and full support from our side.
Namaskar everybody.
Namaskar sir.
Good night, sir.
I would have to break this up. We meet again next week. Okay, please join in. And sir is always available. I'm also always available. Anita
Yes,
ji.
ma'am.
Yeah, best
याद
of luck.
रखिएगा.
Thank you so much.
M.C.Patel
Shubh
sir.
Ratri.
Thank you.
Shubh Ratri to all.
Shubh Ratri. Patel sir,
Thank
end
you.
करूँ?
सभी को.
Good night.
Yes. Hello.
Namaskar,
We can
Shubh Ratri. Thank you
Namaskar.
so much. Thank you so much.
All the best. All the best.